Vidisha, can you hear me? Just checking my sound out.
Hi, sir. I can hear you. Hi, sir.
Yeah, okay. Hi. Good evening, Dr. Toprani. Welcome.
Good evening, all.
Good evening. So we want you to grill the candidate today.
अरे मैं grill हो गया हूँ अभी तो.
I think the presenter is from TMS today. Vidisha, is that correct?
Yes, sir. Kaustubh Gaur is a third year MCH
Yeah.
surgical onc.
He is a third year Dr. Toprani in surgical oncology. So this will be like a mock exam for surgical oncology.
Yes, sir.
They usually get a short case in head neck, sometimes a long case. But most of the time, many of them do get short cases for oral cancer. But thyroid and oral cavity can be a long case as well. So we have 45 minutes, about 45 minutes, 5 minutes are for the introduction, and we have 45 minutes to.
So he is going to present himself?
Yeah, he will be presenting. Vidisha will be moderating.
Okay.
And you, myself, Krishna Kumar, I don't know if Krishna Kumar has joined. And I think, who's the fourth one, Vidisha, the expert panel?
Manish Nair.
Manish is there. I don't know if Manish is joined in from UK. Or he's in Australia now.
He isn't right now, Australia.
Australia.
He's from TMH originally, right?
Yes.
Yes, sir.
His Vidisha looks different or what from your photograph?
No, sir. Probably the different clothes. That's it. Not looking different. You must have seen all in hospital clothes. That's why.
Yeah. What is the rest of the program after 6:45?
I think there's another oral cavity. And tomorrow is larynx and thyroid, if I'm not mistaken.
Okay. If I have to join, I have to use the same link if I want to attend?
Yes, sir. I think the link is same for both the days.
Okay.
Yeah.
Dr. Toprani, there's a talk on radiological anatomy of oral cavity, followed by operative technique bite resection.
Okay.
Then the reconstructive ladder for oral cancers. Deepak is speaking on that. Histopathological risk classification, Toprani, Dr. Asavari Patil is speaking.
Okay.
And role of radiotherapy in oral cancer, Sarvani is speaking. I think that's the lineup for today.
Very good topics today.
Yeah. Okay. So this is kind of a postgraduate recap. So for that, these topics will be reflected.
Okay.
Is Poonam here? Poonam, should we start on dot at 6? Let's keep to schedule. It's a Saturday night. Let's not exceed our time. We have 4 more minutes to go, I think.
Good morning. Sorry. Good evening, sir.
Good evening. Hi. Good evening, Poonam.
Hi, sir. So we'll start, sir?
You let me know. We have 4 minutes. We'll start dot at 5, not at 6. We've announced 6 o'clock.
Yes, sir.
So you let me know when to start. We'll start dot at 6 and we finish on time the first case so that we won't exceed the time. Yeah.
Yes, sir. So we'll start in 2-3 minutes then, sir.
You let me know, then we'll start. Yeah.
Sure, sir. Sure. So, a very good evening to everyone.
Recording in progress.
I, Dr. Poonam Joshi, welcome you all to the National Conference for Postgraduates 2022 on behalf of Department of Head Neck Surgery and Disease Management Group, Tata Memorial Center, Mumbai. So now I would like to invite Dr. Devendra Chaukar, Professor and Head of the Department, Head Neck Surgical Oncology, Tata Memorial Hospital, Mumbai, to give the opening remarks. Over to you, sir.
Hi, Poonam. Thank you. And good evening, everyone. And welcome to the second National Conference for Postgraduate Studies 22. At the outset, let me congratulate Poonam and Sudhir. This is due to their efforts that we started this so-called mock exam. I would not like to call it as a conference. This would be like a mock exam. We used to have, prelims in our school and college. And this is like a prelims for the final exam. So we have examiners from all across the country who will grill the students, and I think there's also students from various institutes who are presenting the cases. Those students who are appearing for their exam in the June of this year. So this would be like a preparatory exam for them. So I would request the examiners to grill the students and prepare them for the upcoming exam. So this is a great effort. This is the second time we are having this. We would, now we have conferences which are offline, and we are starting slowly to have conferences in person. But over the last 2 years, we've realized that online is a very good stage for people to stay where they are and attend many more conferences than would be otherwise possible, because traveling is an issue, and sometimes people don't have time on their hands. So for this postgraduate courses, we preferred to keep it online this year as well. We don't know going on what we'll do. We'll probably do it hybrid. But this year we kept it online. So a great effort from Poonam and Sudhir to get this going last year. And I hope that this continues over the years and gets bigger and better. So best of luck to Poonam, Sudhir, and the entire faculty of TMH, who always contribute to whatever program that is decided, just as if it's their own. So the entire faculty is behind them, and this program has come to you. So without much ado, we will start the program. I think we have our first presenter, Poonam.
Yes.
Can you introduce the presenter to us? And yes. I request, as I was mentioning, one thing that I've seen, Dr. Toprani, I don't know if Krishna Kumar and Manish have joined, is that I've been an examiner now for quite a few exams. And what I see is that a candidate from a particular institute tends to answer things that they have heard during their joint clinic and the way things are done in that institute. So there are some minor differences that we practice. Of course, we all do evidence-based, but there are some few minor changes. And they pick it up in joint clinic and they answer it in the exams rather than basing their answers on evidence and giving a balanced view. So I would request all of you, the first presenter today is from TMH. So I would request Dr. Toprani, Dr. Krishna Kumar, and Manish, of course, is from TMH, but now he's worked in the UK and Australia. So, I would request you to grill them based on and try to get some balanced answers and coach them to give balanced answers in the exam. So back to you, Poonam. Let's begin.
Thank you, sir, for your kind words. Sir, now we'll move on to the main program. So I would hand over the program to Dr. Tirtha Shetty, who is the fellow in Department of Head Neck Surgery. So, Tirtha, please go ahead.
A very good afternoon to all delegates. Thank you, madam. So we'll start with the first case presentation for today. The case presentation is locally advanced oral cavity carcinoma. The expert panelists for this session are Dr. Devendra Chaukar. He is Professor, Head of the Department, Head and Neck Surgical Oncology, Tata Memorial Hospital, Mumbai. Dr. Krishna Kumar Kankappan is Professor, Head and Neck Surgical Oncology, Amrita Institute of Medical Science, Kerala. Dr. Rajendra Toprani, he is Senior Consultant, Head and Neck Surgical Oncology, HCG Cancer Center, Ahmedabad. Dr. Manish Maya, he is Head and Neck Surgeon, John Hunter Hospital, Australia. This session is moderated by Dr. Vidisha Tuljapurkar. She is Associate Professor, Head and Neck Surgical Oncology, Tata Memorial Hospital, Mumbai. Over to you, Dr. Vidisha. Please take over.
Thank you, Tirtha. Is Kaustubh logged in? Kaustubh, are you ready with your presentation? Hello.
Good evening, ma'am.
Dr. Kaustubh? Yeah, hello. Yeah, so Dr. Kaustubh will be presenting the first case. He's a third-year MCH Surgical Oncology resident, and he'll be soon appearing for the exam. And the case that he is presenting will be advanced oral cavity cancer. Right. So please, over to you, Kaustubh. Start your case, and I will be giving any questions if there are in the chat box, along with the questions that will be asked to you by the moderator. All the best. Go ahead.
Thank you, ma'am. And once again, good evening to respected teachers and everyone. I would be beginning with my case presentation. My patient is a gentleman aged 33 years who is a resident of Uttar Pradesh and a manual labor by occupation. He presented with the chief complaints of an ulcer over the inner aspect of the left cheek since 8 months and a swelling over the external aspect of the left cheek since last 3 months. Patient was apparently alright 8 months back when he developed an ulcer over the inner aspect of the left cheek. The onset was insidious. This was attended with a local pain which was aggravated by eating spicy food. The patient started taking some local remedy in the form of Ayurvedic medication, but the ulcer continued to progress and was not healing. At the same time, the patient developed increased salivation. After a duration of 5 months, he developed a swelling on the external aspect of the left cheek. He again consulted a local practitioner and an excision of the nodule on the external aspect of the cheek was performed, after which he developed a recurrent swelling within a matter of days. There is no history of difficulty in swallowing, chewing or speaking. There is no history of change in voice. The patient doesn't give any history of decrease in mouth opening. There is no history of earache. There is no history of any swelling in the neck appreciated by the patient. There is no history of any loosening of the teeth or history of prior similar lesions elsewhere in the oral cavity. There is also no history of any cough, breathlessness or hemoptysis, and the patient doesn't give any history of significant weight loss. He has no comorbidities, and the treatment history includes as described, which was a nodule excision on the external aspect of the left cheek. There is no histopathology report for the same. The family history is not contributory. The patient is a married man with 2 children. There is documented history of tobacco consumption for at least 10 years in the form of gutka chewing 5 to 6 times per day. The patient has quit this habit in the last 1 month. There is no history of smoking. The patient gives history of alcohol consumption 1 quarter per week for last 5 years, which again he has quit in the last 1 month. And the patient doesn't give history of use of dentures. Coming to the general physical examination.
Kaustubh, hello, KK
Yes.
here.
Yes, sir.
I think we can stop here a bit if others agree. And can you just summarize the history?
So my summary would be a male patient aged 33 years with history of tobacco usage from last 10 years who has complaints of a non-healing ulcer in the inner aspect of the cheek, which also has some component on the external aspect of the cheek.
Tobacco and alcohol, right? That's what you said. Tobacco
Sorry.
and alcohol.
Tobacco and alcohol.
Alcohol. Right.
There is also history to assume that the swelling had appeared on the external aspect of the cheek also, which was removed and has a recurrence probably.
Okay. So, what do you think this is from your history?
So against the backdrop of the tobacco abuse, with a non-healing progressive ulcer in the oral cavity with a possible external component, I would think of oral cavity malignancy, oral cavity squamous cell carcinoma.
Oral cavity squamous cell carcinoma. Right. Why do you say it is squamous cell carcinoma from the history?
So 2 points. First one being it is the most common malignancy of the oral cavity, and secondly, it is strongly associated with tobacco use, which our patient has.
Very good. So you said oral squamous cell carcinoma is usually associated with tobacco. So what happens? What does this tobacco do?
Tobacco is known to be a carcinogen in 2 forms primarily, smoking and smokeless tobacco. There are various mechanisms by which the carcinogen induces carcinogenesis. In the smoking form, it's tobacco-specific nitrosamines and polycyclic aromatic hydrocarbons. And in smokeless tobacco, there are other carcinogens, depending on the specific usage of the smokeless tobacco form. So they induce the carcinogenesis.
How do you quantify the tobacco usage?
It is quantified based on the number of cigarettes smoked per day and the number of years of usage. We quantify in terms of pack years.
Very good. And how did the alcohol contribute to the problem?
So, for oral cavity malignancy, oral cavity squamous cell carcinoma, alcohol is known to have a synergistic effect with tobacco. Specifically, it has a multiplicative effect with tobacco. So it may also have contributed to the development of malignancy.
You talked about the patient who didn't have any difficulty in mouth opening. What is the significance of that point?
Sir, there is no history of reduced mouth opening. I am inferring that the patient doesn't have trismus. So I'm assuming that the patient doesn't have trismus because of reflex pain or involvement of masticator space, or at the same time patient doesn't have oral submucosal fibrosis, which would in turn cause reduced mouth opening.
Fantastic. Nicely answered. Yeah, you can proceed. Yeah, others, anything can proceed.
Yeah, go ahead.
Coming to the exam. Coming to the examination, the patient was examined after taking consent. The patient is conscious, cooperative, and well oriented. He had an average belt and nourishment with a body mass index of 22.38. He has excellent performance status, ECOG 0. He was afebrile with normal vitals, and no pallor, icterus, clubbing, or generalized lymphadenopathy was evident. Coming to the local examination, an ulceroproliferative growth on external aspect of left cheek with an overlying scar is evident. The dimensions of this swelling is 5.5 by 5 centimeter. On inspection, the extent includes involvement of oral commissure and lateral half of upper and lower lip anteriorly, and it is seen to extend 4 centimeter behind the oral commissure. Superiorly, it's up to the level of upper lip, and inferiorly, it is reaching the chin. No bleeding is apparent. On inspection of the oral cavity, the mouth opening was 3 finger breadths with an interincisal distance of 3.5 centimeter. Poor orodental hygiene and nicotine staining was noted with carious tooths. No loose teeth were found. And ulceroproliferative growth involving the left buccal mucosa and lower gingivobuccal complex with extent as follows. Anteriorly till oral commissure, posteriorly till second molar with mandibular molar, the RMT being free. Inferiorly, it involves the lower gingivobuccal sulcus till second molar. Superiorly, the upper gingivobuccal sulcus appears to be free, and externally, the skin is involved. The lesion has an everted edge, no bleeding is apparent again, and there are no other lesions visible in the oral cavity. The movements of the tongue, the surface of the tongue, and the floor of mouth appear to be normal. On palpation, there was no local rise of temperature. On palpation, no local rise of temperature was noted externally. The findings of inspection were confirmed. Tenderness over the external swelling over the raw area was found. The lower GVS and alveolus were involved. The induration was reaching till upper gingivobuccal sulcus. Induration of lateral half of upper and lower lip and commissure was noted. The RMT was free on palpation, and externally, the lesion was reaching posteriorly till 5 cm from the oral commissure. The external swelling was fixed to the underlying bone, not mobile. The tongue, floor of mouth, and gingivolingual sulcus and palate were free by palpation also. No sharp teeth were noted. The patient didn't have any reduced sensation over the lip or chin. Finally, examination of the neck revealed a 2 by 2 cm hard mobile left level 1B node with overlying normal skin. Sir, I finished with the examination. Hopkins examination of the oropharynx and larynx revealed no abnormality. And on systemic examination, normal vesicular breath sounds and no added sounds were appreciated. The breath sounds were equal and clear on both sides. To summarize, this is a gentleman aged 33 years without any comorbidities with excellent performance status, with history of tobacco use, with an ulceroproliferative left gingivobuccal mucosal complex lesion, with involvement of the skin, paramandibular disease with single ipsilateral palpable 2 cm level 1B lymph node, with good mouth opening.
Yeah, hi. We could unmute ourselves for some time. Sorry for that. And I think other examiners were also facing the same problem. So, Kaustubh, let me begin. In your history, and Krishna Kumar asked you that question about mouth opening. So, what do you define trismus as? When you're inspecting, what would you say? This patient has trismus, doesn't have trismus? How do you define trismus?
Trismus is defined as a diminished excursion of the mandible to a variety of stimulus, which can be pain or radiation induced or involvement by the tumor or post-traumatic. So,
is there any classification? What do you say? This patient has trismus or no, doesn't have trismus?
Sir, his mouth opening was 3 finger breadths and interincisal distance was 3.5 centimeter. So he would fall on grade 1.
Right. So that's what I was asking you, because finger breadth, your finger and my finger can be different. So what is the criteria for trismus? So it's the interincisal distance. Okay, that's correctly said. So can you quickly tell us the grading and then we'll move ahead?
Yes, sir. So grade 1 is defined as at least 35 mm of mouth opening. Grade 2 would be 25 mm to 35 mm. Grade 3 will be 15 to 25 mm, and grade 4 is 2 to 15 mm.
Right. And you also said you extensively investigated the head and neck areas, and there's a question in the chat box also. why do you want to do Hopkins and examine other areas in the head and neck? That brings us to the question, what is the incidence of second primary and how do you define second primaries?
The incidence of second primary is at least 1% per year, which the lifetime cumulative risk can reach up to 20%.
Right. How do you define second primaries?
The second primary lesions are defined as distinct new lesions within the head neck domain. There are criteria to define as per.
Just tell me the criteria quickly.
Yes, as per the Warren criteria, second primary cancer was defined as a representative malignancy in a distinctly separate area, which was at least 2 centimeters away from the prior lesion with an intervening normal mucosa, and after 3 years of time has elapsed. This was the Warren criteria.
No, I was asking, what is the issue of synchronous? What is synchronous and what is metachronous?
So any lesion which arises within 6 months of the index lesion is labeled as synchronous lesion, and any lesion which arises after 6 months would be called as metachronous lesion.
Okay, great. Go ahead. Krishna Kumar, Manish, Dr. Tup.
Yeah. Just to extend the question, how do you differentiate between a residual lesion and a recurrence?
So the time frame of the lesion is an indicator. If a lesion is appearing very soon after the loco-regional therapy, then it is more likely to be a residual or recurrent disease rather than a second primary. We can take the help of tissue diagnosis. If the tissue diagnoses are distinct, then it is more in favor of a second primary. Then genetic tests can also help us establish the diagnosis. If the genetic alterations of the two tumors are very same, then they are likely to have arisen from a from a single clone. If they are different, then it is more likely to be a second primary.
Is there a time frame for residual and recurrence disease?
So 6 months.
Did you mention anything about the referred pain?
Yes, sir. This patient didn't have referred pain to the ear.
What kind of referred pain are you expecting, and what are the pathways?
Yes, sir. So for oral cavity malignancies, the patient can have ipsilateral referred otalgia. There are at least 2 pathways for oral cavity malignancy. The lesions which are in the buccal mucosa, lower gingivo-buccal complex, irritate and stimulate the branches of the inferior abular nerve, buccal nerve, and these are transmitted to the central nucleus of the trigeminal nerve, which are referred to the ear through the auriculotemporal nerve, and this auriculotemporal nerve supplies the anterior half of explanatory canal and the tympanic membrane. For more posteriorly located lesions near the RMT and tonsillar fossa, the supply to that part is from lesser palatine nerve, and this is transmitted to the glossopharyngeal nerve central nucleus, and this is referred to deeper part of the ear, the middle ear and the internal surface of the tympanic membrane, and a small strip of skin behind the auricle.
What is the implication of having these referred pain?
Sir, the implication of having referred pain is that it suggests an advanced disease with a possible involvement of the nerve, and the tumor is advanced and it is irritating the nerves, and that's why the pain is getting referred.
Yeah, and just extending the very good, by the way. Just extending the questions of tobacco, are you aware of any odds ratio or relative risk which between tobacco and oral cancers and drinking and oral cancers?
Yes, sir. So, smoking tobacco is associated with a relative risk of almost 8 times. The smokeless tobacco is associated with a risk of 5 to 7 times, and alcohol is associated with a risk of 3 times compared to normal.
Are you aware that any how different types of smokeless tobacco has different relative risks?
So the greatest is with the quid and areca nuts. Those substances which release carcinogens like nitrosamines and propylnitrile, they are more likely to cause cancer. Betel quid, it also acts as a carcinogen, but it can act as a carcinogen without tobacco also. So it has a relatively lower.
I'm talking about the values in terms of gutka and different types of smokeless tobacco having a different relative risk to cause oral cancer.
So gutka has a relative risk of 4.5 to 5 times, and betel quid around 2 to 3 times.
I think there is a meta-analysis which says that gutka is at a higher level of 8, but when we talk about Manipuri tobacco and all, it goes as low as 1 to 2. So yeah. Anyways, you did a good job. You can carry on.
Kaprani sir, any questions?
No, let him go.
Right. Kaustubh, you're talking about a paramandibular disease. What does that mean?
The paramandibular disease is soft tissue adjacent to the cortex of the mandible.
Right. So how do you identify it? How do you say that it is present or not?
So it can be judged both by clinical examination and by radiology.
Clinical examination means how is it?
So if by palpation we are feeling that the entire length of the mandible could not be palpated against the skin by the thumb or a finger, then there is some soft tissue which is between the buccal mucosa, which is encroaching into the gingivobuccal sulcus, and the mandible is not being led to be palpated completely.
And the other way of doing it is radiology. Which will you prefer, radiology or the clinical?
Sir, both for operative decisions. But radiology gives the complete extent, which may not be discernible by clinical examination.
What I'm saying is a tumor is sitting laterally on the scans in a coronal CT contrast. So does that mean there is a paramandibular disease always?
Sir, that's why we use the puff cheek sequence to make sure that the laterally placed lesion are actually.
Puff cheek will help you to see a buccal mucosal lesion, but this lesion is probably on the gingival aspect of the tumor. So I'm seeing a tumor on the CT scan sitting adjacent to the gingival aspect. Does that mean it is which is more reliable, the clinical examination or that radiology?
It's a clinical examination in this case.
Right. Very good. Go ahead. How do you diagnose this lesion and what is your staging?
Oh, how will you do the biopsy?
Sir, I will perform the biopsy from the most representative site of the disease, and I will do a punch biopsy.
From where?
Sir, from the edge of the lesion.
Under local anesthesia?
Sorry, sir.
What anesthesia you would do?
Sir, it is an office procedure to be done under local anesthesia.
Would you use a spray, local anesthetic spray, or you would infiltrate?
The sprays.
What kind of biopsy? You would do a punch biopsy?
Sir, I'm sorry, I didn't get the question.
Would you do a punch biopsy or an incisional biopsy?
Sir, I would prefer to do a punch biopsy for a proliferative lesion.
What would be your clinical diagnosis now?
Sir, my clinical impression is that it's a malignant lesion arising.
The biopsy is squamous cell cancer.
Yes, sir.
Now, what more do you want? How would you stage this patient?
So for staging, I will perform a contrast-enhanced CT scan of the head and neck with a non-contrast CT of the chest.
What is your clinical staging before imaging?
So clinically, with skin involvement, the clinical T stage would be CT4A, and with a single mobile ipsilateral lymph node, it would be N1.
Clinically, what do you feel? The mandible is involved or not?
Sir, I could not move the lesion over the mandible, so I'm favoring that mandible is involved.
What other clinical signs you can look for to say that there is mandibular involvement?
Sir, if there is evidence that the patient has dental pain or the patient has fallen teeth, then it is in favor of mandibular invasion.
Any loss of sensation? Paresthesia?
Yes, sir. The sensations of the lower lip is also indicative of mandibular invasion.
How?
By the involvement of inferior alveolar nerve and mental nerve.
Right.
Will you do a PET scan?
Not for this case, sir.
Why not?
Sir, currently the indications for PET scan in oral cavity squamous cell carcinoma include recurrent tumors, those tumors with bulky multi-station disease, nodal disease in the lower neck level, that is 4 and 5, which none of these our patient has. So I'm not choosing to do PET scan.
So why you are doing CT scan of thorax?
So the most common site of metastasis from oral cavity squamous cell carcinoma is the lung. And NCCT thorax suffices to be the staging for distant metastasis, because the incidence of extrathoracic metastasis without involvement of lung is extremely low.
You would do a CT scan of thorax in all oral cancer patients?
No, sir, in only locally advanced.
So does this fall into a category of locally advanced? What is locally advanced cancer? Oral cancer?
Stage 3, 4A and 4B are advanced oral cavity lesions. This patient is clinically T4A with a N1 disease, so hence I would like to stage him with NCCT thorax.
So you said you are going to do a CECT head and neck to see the local extent, right? What is the purpose of doing that CT, this imaging?
So the purpose of local imaging is to establish the extent of the disease, the locoregional involvement, the soft tissue extent of the disease, the bony involvement of the disease, and any possible perineural invasion, and the status of the regional lymph nodes. Also ascertain the involvement of spaces, the masticator space or infratemporal fossa.
So why do you prefer CT and not an MRI?
So the sensitivity for the involvement of the cortical bone is better with CT rather than MRI.
Right. But then you said you wanted to see perineural invasion. You wanted to see the masticator space. So which would be better?
Sir, I would prefer CT itself. If perineural spread is grossly evident on CT, then MRI can be done to ascertain the cranial extent of the disease.
Is the perineural spread seen on CT scan?
So by indirect evidence like widening of the foramina or change in fat density around the nerves at the level of foramen.
Also, the question they're asking you is there any indication of adding an MRI over and above CT? We agree with you that a CT is the primary modality of investigation for tumors near the bone to see bone involvement. Is there any situation that you'll add an MRI after seeing the CT scan?
So to characterize the superior extent of suspected perineural disease, and if marrow invasion has to be confirmed of the mandible, then MRI can also be done.
Rather than confirm the extent of marrow invasion can be better depicted on an MRI to plan your bone cuts, as well as to confirm the extent of peritoneal invasion. So when there is extensive marrow invasion on a CT scan, sometimes you will ask for an MRI to confirm the extent of marrow invasion. Otherwise, your bone cuts can be placed at a wrong place, and you can have positive margins. So that's the time you will probably add an MRI to CT scan.
Okay, sir.
So I think one more very good indication is having a peritoneal invasion, and we have seen few cases, not many, but if the marrow is involved on CT scan and if we do an MRI, we can see a thickened nerve going up to the foramen ovale, and that makes the surgery quite inoperable. So that's a significant change in decision in that case. Do you think PET adds anything while detecting metastasis over CT in chest?
So if we are performing an NCCT thorax, we would not be identifying the mediastinal nodes because it's not a contrast enhanced scan. PET scan would pick up any mediastinal nodes, and PET scan has greater sensitivity to pick up distant metastasis, extrathoracic distant metastasis. So it does.
Anything else? So I think PET has still shown to. It is very controversial actually. Some paper does say that PET picks up more distant metastasis in lung in the range of 3 to 10%. But there are also some other papers which says that if the metastasis is less than 1 centimeter, sometimes PET doesn't pick up, which has been picked up on the CT scan. Why you particularly said non-contrast CT scan? So you will do a CT, then give contrast, and then do just head and neck. You don't want to include thorax for the contrast?
So the timing after administration of the contrast would not permit an optimal evaluation of the thorax at the same time. So and since mainly the metastasis from head neck squamous cell cancer to the lungs are parenchymal mets rather than mediastinal nodes. So NCCT thorax should be sufficing.
Yeah, but it's nothing wrong if you do a PET CT also.
Yes, sir.
Rather than doing a CT thorax.
Yes, sir.
What other things you can? Oh, sorry. Go ahead. Now, I was saying, what other things can you find out on PET scan other than the distant mets, extra pulmonary metastasis? What other things can you identify?
The PET scan can pick up avid nodes in the neck, which are normal by size criteria on CT. So this may alter management.
So how many percentage is that alteration in the literature?
So for change of plan for neck, it's around 13 to 14%.
Yeah. Again, it varies, but yeah, you're right. What else? Anything else? The PET can pick up? You covered most of it. I think one.
No, you were telling about the criteria and all about it.
Sorry, ma'am, I didn't.
Second primary anyways. Yeah.
Yes, second primary. Okay. Yes, sir.
Yeah, sir, there is a question in the chat box regarding the modification of the Warren-Gates criteria, the newer modification of the Warren-Gates criteria. Kaustubh, are you aware of any?
Yes, ma'am. So the original Warren criteria was included 3 points, which was the established new lesion in a distinct subsite and The intervening mucosa should be of at least 2 centimeters, and the revision included the addition of the time clause 3 years. To the best
There's
of
one
my
molecular article which we were discussing.
Ma'am,
I'll just post it in the group. Anyways, TK, go ahead. Sorry to interrupt.
So what are the practical problems of getting an MRI in such patients?
sir, the peritumoral edema will be noted in MRI.
Okay. Then practical issues.
Practical issues would include the availability of doing the availability of doing an MRI itself. CT is easier to do, faster to do.
It is faster. Okay. Then
it is less costly, more widely available, takes lesser time.
What is puff cheek, and is it available in MRI? Can we do a puff cheek appearance in MRI?
No, sir. The amount of time that the patient spends in gantry would be prohibitive for a puff cheek maneuver.
And dental inflammation. You said the dental teeth status is bad in this case. Will that cause any problem?
Yes, sir. The dental infections would produce subtle erosions which might be picked up on MRI, but they may not be related to the disease process as such.
We have around 13 minutes left. Abhishek wants to quickly come in at the imaging and then we'll go on with the management. Abhishek, you want to make a comment? Please go ahead. Can you unmute Abhishek, please?
Yeah. Can you hear me, sir?
Yeah, we can.
So starting from the beginning, CCT is usually done when you are planning a CT of the head and neck. You don't have to do a plain CT thorax that time. We do NCCT when we are doing an MR. So we don't want, actually, contrast is not adding much, but when you are anyways doing a CCT of the neck, you will do at the same time the CT thorax. CT thorax will follow the CT head and neck. So in MR head and neck, you will do a NCCT thorax because it doesn't add, the contrast doesn't add much, but when anyways you are doing it, you will do it. Puff cheek technique is available nowadays in MR. I think with the recent changes which are going to come, that the cortex is not going to be very important. The MR will score over CT head and neck in buccal C also. So there's an article which is published by India, the Divasha group. They have done with gauze piece, and the results are quite interesting to see that you can put a gauze piece dipped in saline and you can get a puff cheek in patients, especially who have dental artifacts. So marrow evaluation will be definitely better. The PET CT, I'm not very sure if you said that the distant metastasis, because having pulmonary metastasis and picking up extra distant metastasis is not going to change management. So by doing a PET CT in that scenario will help. But the incidence of only extra pulmonary metastasis without intrapulmonary metastasis is less than 0.5 to 0.2%. So that's very low. If you have advanced case, if it's changing a management, then only you would do PET CT.
Right. Thank you, Abhishek.
Do we have the CT? Do you want to take us through the CT scan if it is available? Otherwise, okay.
The biopsy was a moderately differentiated squamous cell carcinoma.
Yeah.
This
Can
is
you take it?
axial cuts, contrast enhanced.
You have to take us through what is happening here.
Yes, sir.
What are you seeing?
So I'm identifying a left.
What CT scan is this? What view is this?
So this is a cross-sectional contrast enhanced CT scan. We are looking at the axial cuts, PNS view. So this is the lesion that
PNS view. What view?
CECT, sir. CECT, axial view.
Okay. Yes, go ahead. Tell us.
Yes, sir. So I'm identifying a lesion in the left buccal mucosa. It was almost reaching till upper GBS, and this is the lower extent of the disease.
I know it's a video. It's very difficult for you to explain, but then you will have to show us some normal anatomical landmarks and take us through the tumor and show us whether the tumor is involving the mandible, whether it is involving the skin, extent of the mandibular involvement, if you can say.
Yes, sir.
And tell us also about the nodes.
Yes, sir. So I am identifying the epicenter of the lesion, sir, at this point. It's in the buccal mucosa, and going superiorly, it is reaching till the upper GBS, but I'm not seeing any maxillary erosion. Going further superiorly, the retrointral space, the lateral pterygoid looks okay, the ITF looks okay, the medial pterygoid muscle now looks okay. Further coming down, I'm looking at the masseter, and this is the posterior extent of the lesion, which is just reaching the masseter muscle. And looking at the bone, the dentition seems complete, and there is no gross mandibular invasion. I have bone cut also, sir.
I think that's okay. Krishna Kumar, should we move on with management? We have about less than 5 minutes.
Yes.
How will you manage this patient, Kaustubh?
So I was just highlighting he should be able to take us through the scans properly and
very important.
Show us the extent of involvement, including
absolutely
the local extent, the mandible, the skin, and the nodes.
Yeah.
Okay, go
what
ahead.
Krishna Kumar was trying to tell Kaustubh and others is that when you're looking at the CT scan, there are some important areas that you need to look at. One is the infratemporal fossa for the involvement of these tumors. 2, involvement of the bone, the extent of involvement of the bone, the medullary cavity, to decide whether you have to add on any investigation. And for tumors that are situated lower part of the mandible, you have to look at how close they are to the hyoid and how much is the soft tissue extension. So when you're looking at a CT scan, look at certain important pointers that will help you manage the patient rather than just read the report of the CT scan. So that's important, what Krishna Kumar is saying. Just go through the CT scan and look at its entirety. So how will you manage this patient, Kaustubh?
Sir, I have a curative intent for this patient, and I will offer surgery to this patient.
What is the role of neoadjuvant therapy?
Sir, this is a resectable oral cavity squamous cell carcinoma, so I will offer upfront surgery.
Can we see your clinical photo?
Yes, sir.
For the patient. Yeah. So, what will you resect?
Sir, my plan is a wide excision with wide excision of the buccal mucosa with segmental mandibulectomy with excision of the lateral half of the upper and lower lip. With
so you will excise both the lower and upper lip from midline.
Yes, sir. The induration was reaching midway between midline and the commissure. So I will like to get good margins at that point.
Why do you think there is an edema of both the upper and the lower lip?
So the tumor has extensive infiltration in the subcutaneous plane, and there's also involvement of the oral commissure.
And I can see the edema in the induration probably reaching the nasolabial fold also.
Yes, sir.
So, Kaustubh, what the examiners are trying to ask you is, you said one word that this patient is resectable or operable. Now, what do you mean? How do you define resectable or operable? You know what? You can take out anything in the head neck. There is no problem. So, what defines? How will you define operability for a patient?
So for oral cavity squamous cell carcinoma and for specifically buccal mucosa, peritumoral edema, which is reaching up to the zygoma, is considered as a sign of inoperability. Other signs of inoperability would include disease of the anterior 2/3 of the tongue, which is reaching up to the hyoid or vallecula. And the other inoperable aspect is involvement of high ITF. And the fourth one is involvement of extensive involvement of the skin, which would preclude a resection with a negative margin.
Yeah. So, Kaustubh, my suggestion to you when you're answering in an exam, please say that the ability of the surgeon to achieve a negative margin clinically, or ability to give a meaningful reconstruction and quality of life. These two things, if you can achieve, then the tumor is resectable. Okay?
Yes.
If you can't achieve these two things, either you think that you cannot get a negative margin in this case, or the excision is so extensive that the patient is not going to swallow or talk or there's going to aspirate and have a miserable quality of life, then you would not operate. So these two criteria should be fulfilled. And there is some chat in the chat box regarding dermal lymphatics. Now, this is a very subjective criteria. But yes, if you think that the dermal lymphatics are involved, it's unlikely that you will achieve a negative margin, and then the patient may not be resectable. Okay? So the definition should be crisp and clear, because if you try to say reaching here, reaching there, then between you and me or between the examiners themselves, they will differ on what can be excised or what cannot be excised. It's a very gray zone, right?
The one of the important point in this patient is, Kaustubh, that the lower lip, upper lip and the lower lip both are irrigators, and the edema extends almost up to the midline, or probably it extends across the midline in the lower lip. So how much lip would you keep on going on resecting, and how will you reconstruct that part? Again, that is an issue, and whether you will get a negative margin, that is an issue.
Yes, sir.
Sorry to interrupt, sir, but we are running out of time.
And what sort of a neck dissection would you do if you were to operate this patient?
So this patient has a palpable enlarged mobile lymph node. I would do a comprehensive neck dissection, a modified neck dissection level 1 to 4.
Devendra was asking about neoadjuvant chemotherapy in oral cavity settings. Can you tell in few words?
Sorry, I didn't get.
Devendra was asking about the role of neoadjuvant chemotherapy in such cases. What is the current evidence?
Neoadjuvant chemotherapy or induction chemotherapy in oral cavity cancer, the indications are those 4. Buccal mucosa primary with tumoral edema reaching till zygoma, anterior 2/3 disease going till hyoida vallicula, extensive skin involvement.
So that's for a borderline resectable case, right?
Yes.
Are there any studies which have done, which have considered neoadjuvant chemotherapy in a resectable setting?
Yes, sir. In resectable setting, the studies by Zong was one of them.
What was the earliest study?
By Licitrite also.
What did this study prove?
So there was no difference.
The study and the Zong study and the recent study from your institute.
Yes. So the Licitrite study, no difference in survival, but it improved the mandibular preservation rates and decreased the need of adjuvant radiotherapy compared to the control.
Right. Zong?
Sorry to interrupt, sir, but I think we are running out
So
of
Vidisha,
time.
give us 2 minutes. We'll just wind up. So,
Yes,
Kaustubh, the definition of NACT, this will be asked to you in exam because it's a very controversial topic currently. The best way to answer is to say that for operable oral cavity, there is no role of neoadjuvant chemotherapy currently.
Yes,
okay, the Zong study and the other studies are negative. They do not add to any survival benefit. The only role, if at all, which is again controversial, not backed by level 3 evidence, but is that when you have large tumors where you define borderline operable, the ones, the definitions of going up to zygoma, where you're doubtful of getting a negative margin, okay? Where you're sure of getting a positive margin, you don't operate. But you're doubtful, that is, I may get, may not get. You want to give neoadjuvant chemotherapy for 2 things. 1, to shrink the tumor and see if your resection becomes easier. And 2 is to triage the tumor, because there is some theory saying that patients that respond to neoadjuvant chemotherapy do better in the long run than patients who don't respond to neoadjuvant chemotherapy. So if you want to triage your patients, you would do that. Okay. So otherwise, what is the best way to palliate the patient? If you don't want to operate the patient, what will you do?
Sir, the best way to palliate this patient would be with a palliative chemotherapy. Palliative RT is also an option, but with this fungating wound, palliative chemotherapy would be preferred with good pain control.
All right. So when there is fungation, radiation and Sarbani will cover that in our talk. So we'll not go there. But when there is fungation, that fungation will further open up and it will be miserable. So in this case, you would rather give chemotherapy. But otherwise, the best way to palliate is chemoradiation. The best way to combine chemotherapy with radiation is to give it concurrently. And you would do that unless there is gross fungation like this and you would expect a hole to form there or a fistula to form there with radiation therapy. So you run out of time. We could not, quiz you on the reconstruction, but we'll probably do it in the subsequent part of the.
So you should also know about how to reconstruct this lesion as well as how you.
Yeah, quickly, can you tell us? Can I
adjuvant treatment also?
So my plan of resection is wide excision with a segmental mandibulectomy because the paramandibular disease is significant and the residual height of intact mandible was 7 mm on CT. The skin excision would be extensive. So he is a young male with a good performance status. So for mandibular restoration, I would consider osteocutaneous fibula free flap recon. But the skin paddle would be inadequate to cover that soft tissue defect. So I would try to bring in a second free flap, possibly radial free forearm, to reconstruct the remaining soft tissue defect as well as to help with the microstomia.
Right. Thank you, Kaustav. I think we exceeded our time. Thank you. Examiners, would you like to comment on his performance? We'll start with Dr. Toprani, then Krishna Kumar.
I think he performed very well. The basic questions regarding the history and all, he answered very well. Regarding the investigations also, he was good. And he knew the evidence and he has quoted the evidence also well. So I think overall, I would give him 70% marks out of 100.
Great. Krishna Kumar, Manish?
Yeah, I would also probably agree. He did fairly well. The history and clinical examination was very good. He probably fumbled a little bit in the radiology when differentiating CT and MRI and taking us through the CT scan. He little bit fumbled, but then his practical experience was very good. When he talked about the biopsy taking and all those things, theory knowledge was good. The clinical trial knowledge was good. Definitely, I would pass him with more than average performance.
Manish, your quick comments?
Yeah, I agree with both my seniors, Krishna Kumar sir and Toprani sir. I think, the structural, I think as Devendra sir told you a few times, that structuralization of the answer is important, and that's the only thing I would add. Otherwise, you're doing very well.
Thank you. Thank you, everyone. Thank you, Abhishek. Vidisha, back to you. There's one question which is not answered, contralateral neck. So quickly, I'll take that. If the lesion is crossing midline, approaching or crossing midline, then you do the contralateral neck. The only decision or the confusion comes when it is stopping just short of midline and you cross over to the opposite side to get the tumor out. Well, we don't have great quality evidence, but generally, if the side of the tumor is negative for metastasis, then you would not do opposite side for that case, which is stopping short of midline. But tumors that go to midline, across the midline, certainly you would do the opposite neck. Everybody agrees, or the other examiners have some other opinion?
Agree.
Right.
But having said that, Devendra, this is a difficult patient to treat. Absolutely. And the reconstruction, as Deepak has commented, is a nightmare.
Absolutely. I'm not sure this case is operable. This is probably a palliative resection, if at all.
Yes.
Right. So let's go back. Vidisha, we hand it over back to you.
Yes, sir. Thank you, Devendra sir, and all the experts for an excellent session. So we conclude this session and we have to move on to the next lecture. So I give the session over to you, Dr. Poonam and Dr. Tirtha. Thank you, everyone, for a great contribution. It was great.
It was a smooth presentation by Dr. Kaustuv Gaur and well moderated by Dr. Vidisha Tuljapurkar. Thank you, experts, for their valuable discussion. Now the next session is Radiological Anatomy of Oral Cavity Carcinoma. The experts for this session are Dr. Abhishek Mahajan, sir. He is consultant radiologist, the Clutterbridge Cancer Center, Liverpool. Dr. Sayak Chaudhary, he is assistant professor, nuclear medicine at REC Tata Memorial Center, Mumbai. The talk is given by Dr. Kajri Bhattacharya. She is assistant professor, Department of Radiodiagnosis and Imaging at REC Tata Memorial Center, Mumbai. I would request Kajri ma'am to please start with her presentation.
Okay. I thank the organizers for giving me this wonderful opportunity to speak on this platform, and welcome Abhishek sir. I hope my talk is up to your expectations, and thank you sir for being here. And let me start with my talk without further ado. So my aim of the presentation is walking through the role of imaging in oral cancers, identification of the anatomical structures followed by the pathology, description of the important pathways and spaces and various compartments of oral cancers, and finally the nodes and the how to identify them. So first we start with the role of imaging in oral cancers. Now imaging is essential in the management of oral cancers to plan appropriate therapy. So if it is a resectable disease, we have to plan the extent of resection and reconstruction. And obviously information from imaging can also indicate the treatment outcome. So for example, if we see a lymph node which is involved, it reduces the survival by around 50%. So that is important even if we are not palpating a disease. If we see a small necrotic node, then that is important. So let's start with the imaging. So whenever we are seeing gingivobuccal and RMT squamous cell carcinoma, CCT with puff cheek technique is the preferred imaging technique till now. And what we do is we acquire it in axial sections and thin slices of 0.6 to 5 millimeter, and we reformat it in coronal, sagittal, and optic planes. And we then see in both bone and soft tissue algorithms. Now the bone erosion, as we know, is better appreciated on CT, and soft tissue anatomy in these two cancers is more or less comparable with MRI, so we go with the CCT only. And in the same study only, we can extend it to involve the CCT, thorax and upper abdomen, and we can rule out majority of metastasis. That is basically, as we discussed in the previous talk, that is the thoracic, as well as liver, adrenal, and majority of bony metastasis. I'm not sure whether
मोठं ऑपरेशन आहे आम्ही जेवढं सांगतो तेवढं ऐकायचं दुसरं काही करायचं नाही
CT without puff cheek. This is a CT with puff cheek.
बोलू नको तुझं कोण ऐकणारच नाही तर 10 दिवस फक्त माझं ऐकायचं
Can the organizers host everybody else please excepting the speaker? Can you do that?
Okay, so we move on to how we see this. So what we are looking at is basically a CCT of the buccal CCT imaging for oral cavity carcinoma. So what we do is a puff cheek technique. So this is without puff cheek, this is puff cheek. So we can see nicely how the buccal mucosa is well delineated in a puff cheek CT. And if we have such small lesions like seen in this particular case, this can be easily missed if we don't perform a puff cheek. So therefore a puff cheek technique is of utmost importance when we're looking at buccal mucosa, gingivobuccal and RMT squamous cell carcinomas. In case of tongue and floor of the mouth lesions, where the intrinsic contrast of the anatomical structures is not that much, and MRI is obviously a preferred technique, and we have to perform the MRI in at least 1.5 Tesla. We acquire stir coronal, T2 sag axial, T1 coronal axial, diffusion and T1 contrast. These are the sequences that are taken. I'll show all of these sequences so that the identification of these sequences becomes easier. Now we know the stir has a high sensitivity because it helps us to identify a very small lesion also which may be missed on the other sequences, but because of that only it overestimates, and sometimes edema in the lesion in totality becomes quite larger as compared to the lesion itself. So the stir has a high sensitivity, but it often overestimates. Another important thing is the role of diffusion, especially in tongue cancers. If we have sub-centimeter metastatic nodes, the diffusion plays an important role by identifying the sub-centimeter nodes. So these are the sequences just for identification. The coronal stir is the first sequence which is acquired. Here we can see everything is fat suppressed. So the fat in the buccal mucosa is suppressed. Whatever is fluid appears hyperintense. So any lesion which is there in the tongue can be very easily identified on this. Followed by a coronal and T1 axial. Coronal T1 axial, basically these two sequences are quite important because the anatomy is very well delineated. So if there is a lesion which is involving the fat, it can be very easily identified. So whatever we see in T1 is that the fat appears hyperintense, whereas the fluid appears suppressed. On the other hand, if you are looking at a T2 weighted sequence, the fat again here appears hyperintense, but the fluid, that is the CSF, appears hyperintense. That is in contrast with the T1 weighted image. Now this sagittal sequence is again important if we have to look at the posterior extent of a tongue lesion, that is to identify whether the base of the tongue is involved or not, and always obviously the involvement of the hyoid and the posterior structures. Coming to the role of diffusion, as I already told, it is very important to look at the sub-centimeter metastatic nodes, and I'll show in some examples. And finally, a contrast sequence which is acquired in all three planes, that is the coronal, sagittal and axial, to look at the enhancement of the tumor. Now, the second part of this lecture is how to identify the important anatomical landmarks for the oral cavity carcinoma. So, as we all know, the circumvallate papillae, they form the posterior boundary of the oral cavity. Now, these are obviously not seen on imaging, and we have anatomical correlates for that. Rest of the structures, we'll see how we can identify on imaging. So let's start. So oral cavity, as we all know, it is bounded anteriorly by the lips, laterally by the anterior tonsillar pillars, and posteriorly by the circumvallate papillae. So this is the anatomical definition. And oral cavity itself can be divided into oral cavity proper as well as the vestibule. So let's start with the identification of the oral cavity proper. So if you are looking at a coronal section, then the hard palate lies superiorly, and upper alveolus and lower alveolus on the either side, and the floor is formed by the mylohyoid, and the central part, that is the main content of your oral cavity proper, is basically your tongue. So this is the part which is the oral cavity proper, that is the hard palate and the mucosa covering it, the alveolar mucosa covering the maxilla and mandibular alveolar margins, and the content is formed by the tongue, and the lower part will be your floor of the mouth, which is the lower boundary of it. When we come to the vestibule, if we look at it again in the coronal section, so vestibule will be formed by this gingivobuccal sulcus, which is lying adjacent to the maxillary alveolus, and the gingivobuccal sulcus, which is lying adjacent to the maxillary. So basically upper GBS and lower GBS, and the buccal mucosa covering it. So basically it will be lateral to the maxillary alveolus, and this space, which is delineated by this. So the GBS, the buccal mucosa, and the lower GBS, this part is the vestibule. So it is a paired structure which is again connected anteriorly, as we can see in the axial section. So if we look at the axial sections, what we see here is, this is the buccal mucosa. So the lips will be anterior, laterally will be the buccal mucosa, and posteriorly this vestibule will end in this triangular shaped structure in the axial sections, which is the RMT. Now, RMT, or the retromolar trigone, is a very important anatomical structure, and I'll come to the description of it in the later part of the lecture. So this is how it looks in the axial section. So this is the vestibule, which is bounded posteriorly by the alveolar margin and the central oral cavity proper, and laterally by the buccal mucosa. Now we come to another important part of this, that is the buccomasseteric region. Now the buccomasseteric region is this triangular space which is bounded anteriorly by the zygomaticus major, medially by this buccal vaccinator muscle overlying the buccal mucosa, and posteriorly by this masticator muscle. The contents of this basically lie the parotid gland duct and the branches of facial arteries, nerves, and veins. Now this is very important because it forms a connection with the masticator space, and the disease can spread through there to the masticator space. The next very important structure is the RMT. So RMT, or the retromolar trigone, is basically the mucosa which lies posterior to the third molars of the maxilla and the mandible. So it stretches between the third molars, and it overlies the pterygomandibular raphe. Now pterygomandibular raphe attaches to the pterygoid hamulus, and is a pathway of spread of the lesions to the pterygopalatine fossa. So again, I'll describe that later on and show the examples. This RMT is best identified. It is always obviously seen at this triangular structure as we showed in the axial sections, but it is best identified in the sagittal oblique sections, where we can see this mucosa, this area posterior to the third molar of the maxilla and mandible, as the retromolar trigone. So this is the pterygomandibular raphe which I was talking about. So this is the normal case, whereas in this case we can see an ulceroproliferative lesion which is occupying this retromolar trigone region, and we can see how easily it can spread from this region to the rest of the infratemporal fossa. In the axial sections, this is how the retromolar trigone looks like, as I already showed in the previous slide. So this part is extremely important as it acts as a pathway of spread of disease to various compartments. So the disease can go laterally to involve the buccal mucosa, anteriorly to involve the alveolus, medially to involve the tongue, posteromedially to involve the tonsil, posteriorly to involve the masticator space, and finally, as on this side we can see, it involves the pterygomandibular raphe, and from there it can go into the pterygopalatine fossa. So this is how, this is what is the importance of RMT, and I'll be showing a few cases also later on. So let's come to the anatomy of tongue. So how the important structures anatomically to identify in the tongue and the floor of the mouth I'll be describing now. So first important structures is the extrinsic muscles of the tongue. So the glenoglossus is the largest muscle which is identified in this manner. So as we can see, this is a paired structures lying in the central part of the tongue, thick muscles, and in the sagittal sections they appear as this fan-shaped structures which is going along the entire length of the tongue. Now this sagittal section is again important as is delineated by this red line. So this actually gives us the delineation between the oral tongue and the base of the tongue, which is basically identified by this line which is joining the junction of the hard palate and soft palate with the anterior border of the hyoid. So something which is anterior to it is a part of the oral tongue and something posterior to it is part of the oropharynx. Next is the hyoglossus, styloglossus and palatoglossus muscles. Now the hyoglossus muscle, as we can see, is this one which is lower and more anterior. So this hypointense structure in the sublingual space reaching up to the sublingual space, and something more posterior and superior is the styloglossus muscle. The one which forms the part anterior tonsillar pillar on either side starting from the palate leading up to the tongue forms the palatoglossus muscle. So this is how we identify the extrinsic muscles of the tongue. So rest of the structures of the tongue I'll be describing with the floor of the mouth. Now floor of the mouth, as we know, is the structure which is the space which lies between the mucosa of the oral cavity and the mylohyoid muscle and includes both of these structures. The important part of the contents of the floor of the mouth include the sublingual glands, the deep part of the submandibular glands and its duct, and obviously the mylohyoid muscle and the mucosa of the oral cavity, the geniohyoid muscles and lower part of the hyoglossus muscle. The sublingual space is also considered a part of the floor of the mouth, and therefore the lingual neurovascular bundles also become a part of it. So if you look at the anatomy in the axial sections, here we can see the paired genioglossus muscles. This is the sublingual space, and these black dots which are appearing as phlovoids are basically your neurovascular bundles. And on a more lower level, we can identify this mylohyoid sling, and these two muscles are the geniohyoid. So these are the genioglossus, these are the geniohyoid muscles, and these are the lingual neurovascular bundles at the near the floor of the mouth. In the coronal sections, these will appear like this. So this is basically a lesion on the right lateral border of the tongue. This is the sublingual space which contains fat and appears hyperintense on T1. The lingual neurovascular bundle is well identified, the genioglossus muscle. This one is your geniohyoid. This sling is the mylohyoid, and therefore the supporting structure which lies below it, which is not a part of the floor of the mouth but the supporting part of the floor of the mouth, is your anterior belly of the digastric muscle. So this is how structurally we identified on anatomy. And on sagittal also, again, we see this is the genioglossus muscle, geniohyoid muscle. This is just to show how these two muscles look different on the sagittal sections. Now let's come to the subsites of oral carcinoma and the pathways of spread. So basically these are the important subsites which could be enumerated like this, and I'll be describing and clubbing them together. So basically the gingivobuccal SCC include those which arise from the buccal mucosa and covering mucosa covering the upper and lower alveolus and the GBS. And as we know that the SCC of the lower GBS is the most common oral cancers in the Indian subcontinent due to tobacco chewing. So the important diagnostic information which we have to give to our treating clinicians include the soft tissue spread, the bony erosion and the lymph nodal involvement. So in the soft tissue spread, I'll be not going in details of how we report it, but obviously the important information which clinically changes the staging of the disease. So for example, here we can see this obviously can be delineated clinically also. There is a disease which is reaching up to the skin. There is a fistula which is involving there's an infiltrative disease which is reaching into the quite deep, and then there is a ulceration and there is a fistula formation. This shows the skin involvement on CT. Another large disease, bulky disease, which is there in the pre-maxillary soft tissue. And as we can see here in this case, there is a lot of edema which is reaching up to the zygoma. So in this case, it makes the disease unresectable. So this information is also very important to give to the clinicians. And finally, involvement of the maxillary sinuses and the superior extent of the disease should also be noted and should be notified in the report. So in the previous scan, we also see an enlarged necrotic node. I'll be talking about the nodes in the later part of the lecture. So another important information which is very important to give is basically your pterygopalatine fossa. So pterygopalatine fossa is, as we know, contains important neurovascular structures, and it can be directly involved by the lesion which is there in the infratemporal fossa or something which is coming from the RMT, so if there is any perineural spread of the disease. So this actually forms a gateway to directly transmit the disease to the intracranial structure. So therefore the effacement of fat in this region to be notified in CT is extremely important, and if there is a confusion, we can actually perform an MRI to look for the extent of neural invasion. So another very important information as per the AJCC 8th staging is to give is the depth of invasion. So tumor thickness as well as the depth of invasion we have to measure. So this is how we measure the tumor thickness, that is the the length of the tumor, and then we measure the breadth of the tumor by drawing perpendicular lines to it at the maximum thickness. So when we calculate 2 plus 3, this gives the actual tumor thickness. Rather than measuring like this, we have to draw a line and then draw perpendiculars to it and then add these two. So this gives the tumor thickness. As to coming to the depth of invasion, how we measure it. So if there is a flat tumor, which there is no ulcerative or proliferative component, then the depth of invasion is equal to the tumor thickness radiologically. But when we look at an exophytic tumor, then we actually have to draw an interpreted mucosal plane, that is the plane which should be normally there. If there is an exophytic tumor, then obviously the tumor thickness will be comprising of the exophytic component as well as the depth to which the lesion infiltrates into the base, and the depth of invasion will only be accounting for the infiltrative component, not the exophytic component. On the other hand, if there is an ulcerated tumor, in that case the tumor thickness will be less than the depth of the tumor, because the tumor thickness will be accounting for this much only, whereas the interpreted mucosal plane, that is the straight line, which will be much longer, so therefore the depth of invasion in this case will be higher than the tumor thickness. So for example, if we look at such a case, there is only an exophytic component, there is no involvement of the submucosal fat below the buccal mucosa. So in this case, the depth of invasion will be negligible and only tumor thickness will be important. Next, coming very fast to the masticator space in infratemporal fossa. So masticator space, as we all know, is a deep fascia-lined anatomical space which is contains the muscles of mastication, the mandibular ramus as well as the neural structure in this region. Whereas on the other hand, an infratemporal fossa is basically a pathway which acts as a gateway between the transmission of structures from the intracranial cavity, neurovascular structures, to the rest of the lower down spaces. So basically, it does not include the medial margin of it does not include the mandibular ramus. It basically starts in the medial margin of the mandible, and it includes the lateral margin of the nasopharyngeal mucosa. So this part, basically, your masticator, the masseter muscle is not a part of the infratemporal fossa, whereas the retromaxillary fat and the prestyloid parapharyngeal space is a part of your ITF. Now, there are two types of ITF clinically that you have to, radiologically, that you have to inform the clinicians ITF involvement, that is the infranotch ITF or the supranotch ITF. So if there is a disease here, as we can see in this case on the left side, this is below the level of the mandibular notch, so therefore this is involving the infranotch ITF. On the other hand, here we have already reached the level of the mandibular notch, and there we can see the disease more superiorly at this level also. Here there is involvement of the supranotch ITF, and therefore it makes resection difficult in such case. So this information, providing this information, is also very important. Next information which we have to give is basically your idea of the perineural spread. Now, whenever we are assessing our oral carcinoma, we look at the bone erosion and then we see what are the structures, what are the if there is any involvement of the mandibular canal or the inferior alveolar canal, and if there is any disease going more superior. So if there is a disease in the high ITF which is reaching up to the base of the skull, we have to be very, very careful whether the foramen ovale is involved or not, and if there is any soft tissue which is reaching inside. So CT gives us sometimes CT gives us some idea. So for example, in this case, we can clear-cut see that there is a hyperdense soft tissue in the lateral aspect of the paracellular region. There is not much widening as we can see in this bone window or erosion of the foramen ovale, but we can see here this soft tissue which is enhancing very clearly. And in such cases, we can directly say that there is perineural spread, but often CT is not very confirmatory, and in those cases, MRI needs to be performed. So that is the MRI of the same patient where we can see there is gross enhancement of soft tissue in the supranotch ITF also, and then the tumor is actually going, there is perineural spread through the foramen ovale along the mandibular nerve into the paracellular region. So this information is very important to give to the clinicians. Next is the bony erosion. Now, bony erosion has 2-3 important things. First, we have to see whether how much is the bony involvement. Next is how to comment on the paramandibular soft tissue. Finally, we have to give the sparing of the condyloid process and posterior segment of mandible. So this information is also helpful for planning the reconstruction. This information also needs to be given. So whenever we are looking at such a lesion where there is involvement of predominantly the buccal mucosa and the lower GBS and minor erosion of the cortex, now in this case there is a significant length, so this should be more than 1 centimeter to go for a marginal mandibulectomy. In these cases, marginal mandibulectomy may be planned or contemplated, whereas in such case where there is sufficient length but definitely there is extensive paramandibular disease, erosion of the mandible and involvement of the tongue also in this case, obviously the marginal mandibulectomy is completely ruled out. And in the second case, we can see there is the residual height of the mandible is only less than 10 millimeters, so therefore there is no rule of marginal mandible. Next, we come to the involvement of the inferior alveolar canals. It is best seen in sagittal oblique sequences. What we can see here is very nice demonstration of the inferior alveolar canal. So here there is no bone erosion, normal inferior alveolar canal is seen. In the second one, we can see there is erosion, but there is no involvement of the inferior alveolar canal or the mandibular canal. And in the third case, we can see obvious infiltration into the marrow and involvement of the inferior alveolar canal. In this case, we have to look for the spread of the disease to the high ITF very carefully. Next, coming very fast to the tongue and the floor of the mouth, SCCs. So basically we'll be discussing the oral part of the tongue only, and CE-MRI, as I already told, is the modality of choice because of the poor intrinsic contrast between the tissues. The important points to comment on include the involvement of extrinsic muscles, crossing of the midline, involvement of neurovascular bundles, floor of the muscle base of tongue, vallicular epiglottis and hyoid bone, and mandibular involvement. Now, involvement of extrinsic muscles becomes less important in the 8th AJCC staging because we comment more on the depth of the lesion. So let's see a few examples of this. So where we can see there is a lesion which is present on the right lateral border of the tongue. It crosses the midline, involves the neurovascular bundle, as we can see here in the axial sections also. If we draw a line from this is from the conjunction of the hard and soft palate to the hyoid, we can see this just reaching up to the base of the tongue. The disease also reaches just up to the floor of the mouth, up to the mylohyoid, and there is a necrotic node on the right side. No obvious nodal nodes are seen on the contralateral side. Coming to a more extensive lesion where we can see almost the entire tongue is involved. There is involvement of the floor, frank invasion of the floor of the mouth. There is a disease reaching up to the hyoid and the vallicula, and there is gross adenopathy which is conglomerate with the mass lesion. A further more extensive lesion where there is complete involvement of the floor of the mouth. There is invasion of the masticator space as well as there is invasion of your mandible, which is very clearly delineated. If there is subtle erosion, then we can also go to look for in a CT to rule out if there is any cortical erosion. Finally, the last part, the lymph nodal involvement. So involvement of the signal lymph node, as we know, reduces the survival by half. And we know that the gingivobuccal and tongue SCCs generally spread to 1 and 2 levels respectively. Skip nodes in skip metastasis in tongue cancers to level 3 and 4, and contralateral 1 and 2 levels are also seen. So US guided FNA is the most reliable technique to assess lymph node metastasis in head and neck cancers, and CT and MRI can provide a one-stop shop for assessment of these nodes. Now, the most reliable criteria for metastasis is necrosis, and for non-necrotic homogeneous nodes, there are various size criteria, but generally these are not very sensitive, not always very indicative of the involvement of these nodes. And finally, we have to look at the involvement of the vessels. So, for example, if the carotid artery is encased by more than 270 degrees, it precludes the resectability of the node, and this needs to be mentioned in the report. So this is how a necrotic involved metastatic node looks in the ultrasound. What we can see is a round node with central necrosis. There is involvement of the capsule also with probable spread and extranodal extension. So this also has to be mentioned as per the new staging system. And this is how it looks like. And if we want to perform, we can very easily perform a US-guided FNHC, which will be definitive for the nodal involvement. Other than that, this is how it looks on CT. So basically there is a lesion on the left buccal mucosa, and we can see this necrotic node which is involving of the level 1B. There is no extranodal extension in this case because in that there will be involvement of the fat around it. And finally, lastly, about the role of diffusion weighted imaging. So as I already told, so this is a lesion in the right side of the tongue. We can see a necrotic node in the level 2, but other nodes are very easily identified in the diffusion weighted imaging. And if there are sub-centimeter metastatic nodes, they can be also identified showing same diffusion characteristics as the primary lesion and the major node. And finally, showing this basically nodal mass, which is causing encasement of this internal carotid artery on the right side. So this is not a oral cavity primary. This is a parapharyngeal. This is a piriform sinus mass, where we can see there is involvement of the IJV is completely thrombosed on the right side, and there's complete encasement of the ICA. So if we see such a node in oral cavity or tongue cancers also, this precludes resectability. So this needs important mention. So just last slide, take-home messages. So imaging is of utmost importance in contouring the disease, planning of management and prognostication of the disease in oral cavity carcinomas. CECT with puffed cheek helps to delineate disease in the gingivobuccal and RMT SCCs, and bony involvement is exquisitely demonstrated. Tongue and floor of the mouth cancers are best demonstrated by contrast-enhanced MRI. Lymph nodes are best assessed with FNA, often done under US guidance. CT and MRI can provide one-stop shop for evaluation of territorial nodes along with evaluation of primary. And CCT of thorax and upper abdomen extension to the CCT neck helps to rule out thoracic, liver, adrenal, and majority of bony metastasis. So that's all. Thank you for the patient listening. Abhishek sir, if you have any comments.
Yeah, hi Kajal, thank you for this lecture. You have very well covered all the aspects. Is Sayak there?
Yes, I'm there.
Yeah, Sayak, would you like to add something on PET? I think PET is not covered, so if you can give few pointers on PET.
Sir, as you said that before only answering that question, that the role that PET can add is to identify infradiaphragmatic metastasis, because in CT you are already covering till diaphragm, right? But incidence of infradiaphragmatic metastasis in most oral cavity cancer is very less. In oropharyngeal cancer, there is some evidence that shows that there is 5% cases, there is evidence that infradiaphragmatic metastasis can be present without involvement of lung. But in oral cavity cancer, infradiaphragmatic metastasis infinitesimally small. We have a series of 500 cases done in our institute. So there they found infradiaphragmatic metastasis in 8% cases. However, in most of those cases, there were a concomitant lung metastasis or metastasis of cervical or thoracic vertebrae. So that could have been detected by CT scan also. So PET doesn't add much extra value in oral cavity cancer. However, few papers are there that do say that patients with N3C and 3B disease, like basically bulky neck nodal disease, in those patients, PET has a role in detecting more metastatic sites than CT. And if you are planning for the patient for palliative chemo or any targeted therapy, then for post-treatment assessment, for post-treatment assessment, you should have a pre-treatment scan that shows the whole metastatic burden of the disease. That way you can properly assess the disease in the post-treatment scan. So apart from that, I don't think PET has much role in initial staging.
So, Kajri, there's one question from the chat box. It's any role of CBCT in mandibular invasion, getting a CT done. CT done spices. I think the candidate wants to ask CBCT role. You think there's any role of CBCT?
I'm not aware, sir. I would like your help in answering that question. If you have any
CBCT role in mandibular invasion, there's no need to do an extra CBCT because you're getting a CT of the neck anyways, and you will have bone algorithm images which will help you in picking up the mandibular invasion. CBCT does have a role if you are looking for osteoradionecrosis post-treatment, and if you are relying heavily on your OPGs, and CBCT can be a less radiation challenging tool to assess the osteoradionecrosis. So CBCT does have a role in osteoradionecrosis, but not in detecting primary mandibular invasion. PET-CT should be judiciously used in patients who have undergone radical CT-RT. If the patient is undergoing radical CT-RT, you've done a baseline PET-CT, the response assessment should be done with after the completion of the treatment with PET-CT, because you have to document the response on PET-CT, and then subsequent follow-ups can be done with routine CECT. So that's very important. Bulky nodal disease, lower jugular nodes, and advanced T4 diseases needs a metastatic workup. NCCT thorax versus PET CCT depends on the center you're working in and the limitations of the resources you have. So that's it. Also, Sarbani Madam has added that for dental rehab, the CBCT has a role. So I agree with you, ma'am. Thank you. I don't have any further points. One thing which is very important is if you are doing a follow-up for patients who have residual nodal disease after radical CT-RT, ultrasound can be a challenging tool because you will see necrotic nodes, and ultrasound-guided FNAC also may not yield much in a post-treated neck for evaluation. Vinayak wants to say something. Vinayak, you can unmute yourself and say. Vinayak, you raised your hand. There's another question. Can we differentiate recurrent mandibular disease versus ORN? No, it's very challenging. You can only pick the mandibular marrow involvement on CBCT. That's like a moth-eaten appearance with cortical thickness. So if you've seen cases of osteomyelitis, ORN behaves something similar. The outer and the inner cortex will start thickening and the marrow will become moth-eaten. But in a malignant recurrent disease, the outer and inner cortex will also start eroding, and you will not see this moth-eaten appearance. So you typically have this sequestrum formation in ORN that should always be kept in mind.
And sir, I would like to add one point regarding Warden. So in Warden, PET CT has a very typical appearance. It will be like diffusely seen along the length of the length of the bone. The uptake will be there instead of focal uptake along soft tissue focus and all. So that is a very typical finding. And there is a paper that actually looked into the specificity of this different uptake patterns of Warden in PET CT. So that is there.
Sajri, one last question is there from Shikhar. He's asking if you can elaborate on the recurrent versus post-treatment changes. I think if you can just give a short note on this.
Sir, I didn't get your question. Sorry.
In post-treatment changes versus recurrence, if you can help, what are the...
So if we are looking at the post-treatment changes, initially what we see is, so if there is some enhancing expansile lobulated soft tissue, generally what post-treatment changes present to us is basic fatty infiltration and fibrosis. So fibrosis is generally seen as a homogeneous non-mass-like enhancement with no significant mass effect on any of the adjacent structures. In addition to that, there will be fatty infiltration of the flap or any reconstructive surgery that has been done. On the other hand, if you're looking at mass or a recurrence lesion, what we see is an heterogeneously enhancing lesion, which obviously has a mass-like appearance. In addition to that, there can be involvement of contralateral nodes if there is an extensive recurrence. And any point you would like to add, sir?
I would just like to add that it's important to use NIRADS, which gives a very comprehensive score, and it improves the communication between radiologists and the treating physician with recommendations. So stick on to NIRADS, and then you have better communication. Also the recommendations for how to manage the each and individual score. So start using NIRADS in your practice.
Sir, I would like to add one point. Regarding post-treatment changes and versus the PET CT definitely has a role in detecting recurrence versus post-treatment change, and we use NIRAD score for PET CT also. But the thing is that it is very good as a negative predictive tool because that NIRADs 1 and 2, they have decent negative predictive value. Like NIRAD 1 has like almost 91% negative predictive value. But when you look at it in terms of NIRADs 3, it doesn't have a very good positive predictive value. So any uptake that we see in PET CT will have to be very careful before we consider it disease and biopsy it, because in many of these patients, especially post-RT, biopsying post-RT, there is a lot of inflammation and all. Targeting a site for biopsy can be a bit difficult. So these NIRAD lesions are very tricky. So we'll have to take into other clinical criteria and other things. And when the scan is done, the timing of the scan done is very important. It should be done at should not be done before 3 months. It should be done after 3 months and above, because before 3 months, chances of false positivity is very high.
say that NIRADs to use in all kinds of treated cases, whether radical CTRT post surgery or any kind of patient. So agree with you, Saik, that timing is very important in radical CTRT. But even if the patient has undergone radical surgery or is undergoing adjuvant chemoradiotherapy, kindly use NIRADs because it will definitely improve your. Otherwise, giving a non-structured report and not giving any recommendation is even worse.
Yes, sir. Yes, sir. Obviously, we also follow NIRADs.
So we have to
wind up.
exceeded the time, sir.
Thank you, everyone.
So thank you so much, the experts, for giving your expert opinions. We'll move on to the next part of the session. Thank you.
Thank you, Dr. Kajri Bhattacharya, for making this topic easy for us to understand. And I thank our experts, Dr. Abhishek Mahajan sir and Dr. Sayak Chaudhary sir, for their insights on this topic. Now coming to the third session of the conference, it is operative technique discussion by composite resection. The experts for this session are Dr. Pankaj Chaturvedi sir. He is Head and Neck Surgical Oncology, Deputy Director CCE, Tata Memorial Hospital, Mumbai. Dr. Arvind Krishnamurthy, he is Professor, Head and Neck Surgical Oncology, Cancer Institute, Adyar, Chennai. Dr. Ashok Das, he is Professor, Department of Head and Neck Oncology, Dr. B. Barwa Cancer Institute, Guwahati, Assam. The talk is by Dr. Poonam Joshi. She is Associate Professor, Head and Neck Surgical Oncology, Tata Memorial Hospital, Mumbai. I would request Poonam ma'am to please go ahead with the presentation.
Thank you, Tirtha. So I once again welcome you all, and thank you, Dr. Arvind and Dr. Ashok. I will be talking on the topic, that is the bite composite resection or the bialveolar resection. And I would request both of you to interrupt me as and when you feel it is appropriate. So if we look into the history of oral cancer surgery, it is actually very interesting. I would just, when I went through the literature, I could see that the history of oral cancer surgery started with the resection of tongue cancers. So that history dates back to 17th century. And initially the tumor resection was started with the use of ligatures, and these ligatures were tied around the tongue tumor. And this the blood supply was hampered, or was and the tumor was strangulated, and this tumor then sloughed out of on its own after 8 to 10 days. Then there was the use of this chain-like thing, which was an instrument, and this tumor was strangulated with the help of this, and this was followed by the use of I think this is the first cautery which was used, and this was called as the galvanic apparetia. So this had a crushing wire-like loop in the front part, and there was a placement of battery inside this area through which heat could be transmitted to this wire. And with the help of the crushing effect and the heat, the tumor of the tongue were excised. This was followed by the era of composite resections, mainly for the mandible cancers. So we have seen that the term commando and the composite resections are used most of the time as interchangeably. Initially, the term commando or the composite resection was used for the hemimandibulectomy, radical neck dissection, resection of the base of the tongue or palate, or wherever the primary tumor was located, along with the tracheostomy. So how come this term, this commando operation came into picture? So during the Second World War, there were a lot of attacks going on in Europe, and that time the armed forces were given special training and they were called as commandos. Similarly, the head and neck surgery was evolving and it was quite radical at that time, needing a radical neck dissection with major surgeries, and they also needed special training of surgeons of that era. So this term was taken from there and these surgeries were called as commando surgeries. Dr. Grant Ward was the first one who carried out in continuity removal of primary along with the resection of neck nodes. However, it was Dr. Hayes Martin who made this procedure more popular and named it formally the commando procedure. So, what is a bite composite resection? A bite composite resection is basically the excision of the superior and the inferior alveoli with the intervening interalveolar tissue, which is like a bite. And this is done along with the soft tissue formed by the four muscles of mastication. So, when I tried to look into the literature, the data regarding the bite composite resection, though there is a lot of data for the composite, there was hardly any literature about the bite. So, as we know that the lesions which require bite composite resection, they mainly involve the buccal mucosa, gingivobuccal sulcus, and retromolar trigone area. And these are primarily Indian subcontinent disease. And they are associated with the habit of prolonged exposure of tobacco to these areas. This term has been mentioned in literature by Dr. Chalker et al. So, what are the indications of bite composite resections? So, any tumor which involves the retromolar trigone area and then involves the upper gingivobuccal sulcus or upper alveolus. The buccal mucosal lesions which involve the upper and lower gingivobuccal sulcus. So, as we all know that the retromolar trigone area is a triangular area which is formed on the medial aspect by the temporal crest on the mandible, on the lateral aspect by the anterior border of the ramus, and base is formed by the posterior to the socket for the third molar. So, the route of RMT lesion spread, as we know that retromolar trigone area is basically considered as an anatomic crossroad where the muscular and the nervous components converge. From here, the tumor can spread to the buccinator muscle, subcutaneous tissue to the skin, or it can come medially to the medial pterygoid muscle. Here it can go to the parapharyngeal fat, to the tonsil, or it can go to the hard palate. So, if we see that the retromolar trigone area is basically formed by the a thin mucosa over the mandible, and just beneath that lies the pterygomandibular raphe. This pterygomandibular raphe is basically a fibrous condensation of buccopharyngeal fascia which extends from the level of humulus of the medial pterygoid plate up to the mylohyoid ridge on the mandible. So, this pterygomandibular raphe is an important conduit in the spread of head and neck malignancies. The pterygomandibular raphe, along with the muscles, form the pterygomandibular space, which contains the lingual and alveolar nerves, and they get involved in the early course of the disease. So, if you look into the spread of the gingivobuccal sulcus complex disease, these gingivobuccal sulcus disease, they mainly spread to the buccal mucosa. From buccal mucosa, they go to the buccinator muscle and then they ulcerate through the skin. The upper GBS lesions, they basically erode into the maxilla and then they go intrasinus. So, as we see here once again, so if we see, this is a diagram which shows that this is the upper gingivobuccal sulcus, this is the lower gingivobuccal sulcus, this is the buccal mucosa, and this is the buccinator muscle, which is considered as the anatomic barrier to the lateral spread of the tumor. So, once this tumor spreads to the goes through the buccinator muscle, it can go into the buccal space, from where it goes to the buccal pad of fat and then the retroantral fat, and then can spread to the infratemporal fossa, or it can follow a lateral course where it can go to the masseter, subcutaneous tissue and to the skin, as we saw in the previous slide also. So, what are the routes of bone invasion? The tumor can, in a dentate mandible, the primary tumor that spreads through the junction of the, it spreads through the junction of the fixed mucosa and the refracted mucosa, as we can see here. Whereas in a edentulous mandible, the spread of the tumor is through the socket of the gum or the teeth. So the spread of the maxillary alveolus tumor is also into the maxillary alveolus is also similar to the mandible. So when we are planning to operate a oral cavity cancer, there are certain factors which we have to consider when planning a resection. So the foremost important among them is the intraoral assessment of the disease, then the skin involvement or the putty orange appearance of the skin, the paramandibular disease, and the deep soft tissue infiltration. So coming to first the intraoral assessment of the disease, whenever we are assessing the disease, it is important to look for the epicenter of the disease. As we can see here, the epicenter is the buccal mucosa, and then the extension to the upper gingivobuccal sulcus, lower gingivobuccal sulcus, its proximity to the oral commissure, its extension into the retromolar trigone area, and the palate. Regarding the assessment of the skin, the careful inspection and digital palpation is the way to go. However, there is a study which is published by Dr. Chokar et al., which has shown that CT scan is an effective radiological tool in predicting the depth of invasion preoperatively, and the objective preoperative measurement of distance between the tumor and the skin can help the clinician in achieving the adequate soft tissue margins. So how do you assess the skin involvement? The skin involvement can come in various forms. As we can see here, it can look like a putty orange appearance, or it can be the appearance of a tethered skin, as we can see here, with the loss of hair follicles. It can be in the form of a impending ulceration, or it can present as involvement of the skin with frank ulceration. So then another point which is important here to consider is the paramandibular disease. So I think the previous session also there was some discussion regarding the paramandibular disease. So what is a paramandibular disease? A paramandibular disease is basically a soft tissue disease which lies adjacent to the mandible in a vertical plane. And this basically acts as a surrogate for the segmental mandibulectomy. So we can see here, this is the slide where we can see this patient has a paramandibular disease, basically in the soft tissue. Mandible is not eroded, and if we see this over the skin, this area, there is edema and soft tissue disease. So for this patient, a segmental mandibulectomy was performed so as to achieve good bone and soft tissue margins. Dr. Arvind and Dr. Ashok, hello.
Hi, Poonam.
Hi, sir. Pankaj sir, good evening, sir.
Good evening.
Any point on this, sir? Because we have seen that paramandibular disease is basically more of a subjective term, and most of the time there is not any objective criteria to define it. So, sir, how to go ahead in these situations?
So, thank you, Poonam. I think it was a wonderful discussion, and I learned a lot from your presentation. And basically, what we have to understand that whenever we are removing the tumor, we have to have a tumor-free margin of at least 1 centimeter from all sides. Now, when we say all sides, that means all the mucosal margin. And in this case, what you are showing, there has to be a bony margin and there has to be a soft tissue margin. So the ultimate aim of any surgeon for such patients is that you have to have at least 1 centimeter or thumb breadth of the lower border of the mandible. And when we have to achieve that, there has to be a soft tissue cuff around the tumor on the paramandibular side as well. If you are able to achieve that, that is an appropriate dissection. If you are not able to do that, then in that situation, Either you plan for segmental or you plan for, posterior segment mandibulectomy, sometimes in the absence of segmental that we might do. But you are right that subjectivity is one thing, but we know that paramandibular, when we say the word, means that the tumor may have already infiltrated from the cortical surface of the mandible. And therefore, when you do any kind of stripping or any kind of taking it away from the mandible, your margin on the bone and the soft tissue would be positive intraoperative.
So, Dr. Arvind, you would like to say something?
I think Pankaj has elegantly summed it up, and very important to get soft tissue margins also around, and of course, as you said, paramandibular, traditionally, of course, the thing was that it is considered a contraindication to do a marginal mandibulectomy. But of course, concepts may keep slightly changing. But in the interest of the current audience, I feel that we have to stick to standard literature. So let's not complicate things by putting more terminology. I feel like in a traditional teaching, they say that extensive paramandibular spread may be a contraindication for a marginal mandibulectomy. And as Dr. Pankaj said, like earlier, a lot of people used to do what is called as a periosteum stripping and all those things. And there is a high chance that you would sort of, it was mentioned by certain groups in the UK that you do periosteal stripping, but that practice has not sort of caught up. So it's preferable that you get good mucosal margins, good soft tissue margins, and good bony margins also. And in this case, traditionally, you would possibly land up by doing a segmental mandibulectomy in such patients.
Correct. So I think we'll go ahead. Yes, Dr. Ashok.
One point I just want to make. The only fallacy in periosteal stripping is the margin in final histopathology report, because the pathologists, they do not, basically they do not look into this matter, and in their final histopathology report, eventually they give a closer margin that become an issue sometimes, even with marginal mandibulectomy. Also, after doing a good marginal mandibulectomy, the pathologists, they give a closer margin on the medial side. This is a very gray area. So many times the pathologists do not include the distance of the the bone attached with the soft tissue specimen. Eventually, in the final histopathology report, the medial margin or the inferior margin that comes closer, and that's become a matter of debate in the joint tumor board for inclusion of addition of adjuvant radiotherapy.
Correct, sir. So I think
to add some, there's a question in the chat. I think one doctor had asked about the role of neoadjuvant chemotherapy in mandibular preservation. This was something that I just wanted to sort of it's I think there is good phase 2 data from the Tatas, and of course you are all a part of the study, and I assume that a phase 3 study is ongoing. So we will sort of have to wait, but I think. Even in it's not a newer concept. Maybe even in Lisa Lecitra's paper in 2003 itself, she had about 20% of the mandibles that were actually preserved by giving neoadjuvant chemotherapy. But then this concept has not yet become standard of care. It is in a very exciting area, and we will await phase 3 data before actually making it a standard of care.
Sure.
So if you want to add something.
So I completely agree with you, Arvind, that such things should not be part of the postgraduate discussion. They are something that to be discussed at a level where we have understood the biology of the disease, the response to treatment. And once we have evolved, then we take it as an experimental treatment. But certainly, if you have given induction chemotherapy to a stage 4 disease and the disease has shrunken, then at that point, the confusion may arise, and you have to take the patient in confidence whether you want to do a segmental, marginal, or as per the original. The data is completely fluid, as Arvind rightly said. One of the questions that has come, that if we are able to pinch the skin, should we save the skin? I would again say that it is not pinching the skin. If there is any tethering of the skin, because sometimes it depends upon how hard you pinch the skin and you'll be able to lift anything. But any time, if you put your hand on the skin and you can feel the back of the tumor, don't try to pinch it. But if you can feel the tumor from the skin has to come out. And the reason is very simple. When we say buccinator is the barrier, the difference between the distance between the buccinator, the buccal pad of fat, and the skin is less than 1 centimeter in many people, especially when people are having pan masala and submucous fibrosis. So it is less than 5 millimeters sometimes. And therefore, I would say that skin, when we are planning to remove, we should be liberal. B, when we are planning the neck incision, especially for the postgraduates, the neck incision should be planned only when you have marked the skin excision. And it should be in conjunction, because small skin incision can be taken en bloc, and the closure can be done by the rotation of the neck flap itself. It's a small defect.
Correct, sir. So, sir, thank you so much. Yeah. So we'll go ahead with the next slide. So we were discussing that what are the important factors which we have to consider while planning for the intraoral resection. So another important point is soft tissue infiltration, which we should be aware of. So again, this is almost a similar slide where the soft tissue infiltration can look the involvement of the overlying skin, or it can be like we were discussing these diffuse edema over the skin where the margins are not very well defined. Even the soft tissue infiltration can present in the form of trismus due to the, this could be due to the infiltration of the infratemporal fossa. So these 4 points one has to consider while planning the resection of the tumor. So like Pankaj sir just said, that there are various kinds of incisions which we usually use for in planning their approach to the tumor. So if we see, this is the one of the most commonly used the incision, which is a midline incision. Here usually this is preferred in cases where the tumor is away from the oral commissure, and since we are not cutting the angle of the mouth, there is we are saving the marginal mandibular nerve supply to the lip and the other muscles of the face. In that case, it is considered that the oral competence is better. This is the other incision which is taken as the angle split incision. Usually it is taken when the tumor is close to the oral commissure. Then this is the third incision which we call as the chin sparing or the McGregor's incision. This is again taken with the aim to have a better cosmesis. But when I tried to review the literature, I saw that this incision, which is a modified McGregor's incision, or also called as the chevron chin sparing incision, this is considered as the best. It has these stepped incisions onto the lip and onto the chin, and is then extended onto the chin, around the chin, and this is considered to give the best cosmesis to the lip, good sensation to the lip, and better oral competence. So Dr. Ashok, in your practice, do you often use this kind of incision, or this is more of a literature review? Because at TMH also, we don't often use this kind of incision.
Yes, I totally agree, Poonam. We follow the same incision. But need to be very careful if the lesions or if the excision comes closer to the angle of the mouth, then we have to split in the angle. That's the difference.
Correct. So I think the next kind of incision, which already Pankaj sir said about, is whenever the skin is involved or is close and you feel that the skin is not pinchable, in that case, circumscribing the involved skin and then extending the incision accordingly is the way to go. So now coming to the bite composite operative steps. So we already spoke that careful assessment of the intraoral disease is important. So in this case, which we are going to discuss, we took an angle split incision for the obvious reasons we already discussed. A level 1 to 5 neck dissection was performed before starting the primary because of the involved neck nodes. And then mucosal cuts were taken at a distance of 1 centimeter from the primary tumor after careful inspection and the digital palpation of the disease. The incision was taken up to the depth of subcutaneous tissue, taking the buccinator muscle as the soft tissue margin. So, Dr. Arvind, what is your take on this thing that when there is a surrounding leukoplakia or there is surrounding melanoplakia, what margins do you prefer in those cases?
Yeah, I think that's a very important question. We'll have to actually categorize the lesion properly, because there are various types of leukoplakias, so if it is a sort of a more ominous, the sense like if it's a sort of an erythroplakia or a leukoerythroplakia, which is ominous, and I think you will have to sort of, all this you'll get by a good intraoperative clinical examination and also sometimes by palpation. And as you rightly said, no, it is you'll have to also palpate the lesion. You'll also have to see the induration. But in case where there is an erythroplakia or a leukoerythroplakia wherein you suspect that there is going to be a continuation of the tumor, then you'll have to give margins for that as well. But if it's a simple melanoplakia or a homogeneous leukoplakia, in that case, of course, there's a clinical call. You will have to sort of, give. So the important aspect is that you'll have to give margins for the visual aspect of the tumor and also for the induration. So that's more important, I think. So the soft tissue margins are getting a negative soft tissue margin is a very, very critical aspect in these cancers.
Correct. So going ahead with the presentation. So this is followed by raising.
Only one thing. Arvind very rightly said. So when we include the dysplasia or the erythroplakia or leukoplakia in the margin, the depth of excision will vary when we are dealing with the leukoplakic lesion versus the one in the malignancy. So what happens that Arvind is right, that if you have dysplasia or leukoplakia in the margin, we have done our own study and we have found that the survival is almost equivalent to margin positive when there is a leukoplakia. Now coming to excision, as I said, that you can tailor-made your incision where the depth of excision can be lower on the other side. But what is more important, that whenever we are doing the excision, please do not think of reconstruction at the time of excision. See what happens, many of the surgeons, they do the reconstruction themselves. So I want the youngsters to remember one thing, that reconstruction should be planned only when the excision has happened. But in your back of your mind, when you are thinking that I have to do a primary closure, I have to do a PMMC, I have to do some kind of local flap, then you start, compromising on everything.
Correct, sir. So I think Pankaj sir and Arvind sir has already elaborated it very well. I will be going to the next step. So this is followed by the raising of the cheek flap. This cheek flap is raised in a plane between this you can see subcutaneous fat layer, and these are the facial muscles along with the buccinator. So plane is raised in this subcutaneous plane, leaving behind the buccinator muscle and the other facial muscles at the lateral soft tissue margin on the tumor. So as we can see here further, this raising of the cheek flap. This is followed by defining the anterior bone margin. So then there is like the facial artery and the vein are ligated lateral to the buccinator muscle, and the upper flap is also raised. So while raising the upper flap, there's one word of caution, that when the upper flap is raised, especially the new students or the residents have to be careful that the flap should not be raised over and above the zygomatic bone. And the assistant should be careful not to be pulling the upper flap with too much of force. It is because that because of the traction injury to the zygomaticotemporal branch of the facial nerve, which lies over the zygomatic bone. So this needs to be taken care of when raising the upper flap. So once you have raised the upper flap, the mesenteric and the parotid fascia, which together is called as the parotidiomesenteric fascia, is exposed. This fascia is basically a condensation of the superficial layer of deep cervical fascia. It is loosely adherent to the masseter while it is tightly adherent to the parotid. Once we divide this fascia, the parotid duct is exposed. So this parotid duct, as we can see here, we have tried to mark it. It follows a transverse course onto the masseter. It follows this course onto the masseter, and then it traverses to the buccal pad of fat, from where it turns abruptly medially to penetrate the buccinator muscle, and it opens against the upper second molar tooth. So a careful ligation of parotid duct is a must, as it can lead to salivary fistula leak in the post-operative period and can lead to lot of complications. Along with that, one point I would like to add here is that in 1/5 of the cases, this parotid duct is accompanied by a accessory parotid tissue, which separately should be ligated, as this can be another source of parotid leak in the post-operative period. So after we have ligated the parotid duct, the plane between the mandible and the this parotid gland is created by further dividing the fascia, as we discussed, the deep cervical fascia attachments onto the masseter, and this is done along with the detachment of the stylomandibular ligament, which is again a facial condensation of tissue between the styloid process and the mandible. This is followed by the division of the masseter muscle, and as we cut the masseter from its origin onto the zygoma bone, there is the temporalis muscle comes into the picture. So we can see here, this is the muscle, masseter muscle. This temporalis muscle has been dissected, and the condyle has been exposed. This we can see is the pterygoid plexus of veins, which is lying between the temporalis muscle and the lateral pterygoid muscle. So Dr. Ashok, would you like to tell the residents that the points of caution at this point when we are trying to expose the condyle?
Yeah, it's a very good point, Poonam. So whenever we need to take the mandible from the joint, then we need to be very much stick to the bone, because just near this neck of the mandible where you are putting your cursor is the maxillary artery. So you need to be very careful in dissecting that part. As far as possible, we should stick to the bone. We should keep our cautery at the bone. In that way, we can be. It's very safe in operating that area. And secondly, whatever you are showing the pterygoid venous plexus, we should be very careful after cutting the masseter, because the lateral pterygoid, mostly the branches of the facial artery, maxillary artery, and the pterygoid venous plexus, it's over the lateral pterygoid muscle. So we should be very careful in that area. That's all.
Correct, sir. So I think yes.
There was one point in the chat. I think a lot of thing is happening in the chat at parallel as you are elegantly speaking. I thought this point is important to clarify. I think Dr. Shubhra had asked whether it's a good idea to save the competence of the lip by taking an incision away from the commissure when the commissure is free and all those things. I think that is a very important aspect. But my only thing, and I'll ask Pankaj also to sort of add on to it. Of course, there are a lot of other comments in the chat. It's very important initially to achieve oncological clearance first, essentially. Theoretically, of course, you can do many things in the sense sometimes if you can actually raise a visor flap, you can take it above, especially if the disease is crossing the midline. And if you don't take the commissure then I think you could be cosmetically good. But I feel it is very important for the larger audience to know that it is very, very important for us to visualize the tumor completely and sort of, be very, very safe when you are taking the three-dimensional clearance for these patients. I think that's the most important aspect. So in order, it will be oncological importance first, and then subsequently you should have the cosmetic, aesthetics, and the functional. So it would be in that priority. And Pankaj, you can sort of, because it's a very important learning point that youngsters should sort of understand.
So I completely agree with you that whether commissure has to be preserved, whether lip split has to happen at the midline or at the commissure, every decision is taken after oncological safety is confirmed. And once you have done this, all kinds of things, like if the lesion is coming up to the close to the commissure, there is no point in preserving the commissure. At that point, if you try to preserve the commissure and you have a thin rim of mucosa and you have post-op necrosis, that is worse. And what we are trying to say that this is the postgraduate teaching. This is not the experts who are listening to us. So we have to be very cautious that some things that have to be done under parental guidance is not told to the PGs.
Well, just want to add a point here. I think Arvind was asking whether the incision to be made exactly at the commissure or just little away from the commissure. Some surgeon practice this, they don't want to disrupt the commissure, they take just few millimeter away from the commissure. I think that hardly make any sense in the competence of the lip, because the whole idea is to keep the competence of the lip, and whether it's in the commissure or a few millimeter away from the commissure, I think the outcome is same almost.
Correct. Absolutely. And it has to be based, basically, as Pankaj said, you have to tailor it based on the extent of the tumor, and you're achieving good clear margins three-dimensionally, both in the skin and the soft tissue. Everything else would sort of, it's important, but it will be secondary to the first phase.
Yes, sir. So I think, yes, sir. So moving ahead with the presentation. So like after this, here we can see we have exposed the condyle and we have exposed the coronoid as well. So after that, the assessment of the, again, floor of mouth is especially important before taking a final mandibular cut, as many a times you will see that the disease is creeping into the lower gingivolingual circles. So this is another important point which I want to emphasize upon. So this again is followed by the mandibular osteotomy with the help of this bone reciprocating saw. Then the floor of mouth muscles are detached. Depending upon the disease in the floor of the mouth, if there's disease in the floor of the mouth, a margin of these floor of mouth muscles can be taken. However, if it is free, they need to be detached. Here we can see the detachment of the anterior belly of the digastric. The lingual nerve is coming into picture, which needs to be sacrificed because the disease is involving the retromolar trigone area. This is followed by the detachment, or I said, that with the margin of the mylohyoid muscle, if the disease is in the floor of the mouth. So once we have detached the floor of the mouth, the incision is then extended into the hard palate. While taking the cut onto the hard palate, the residents need to be careful about the bleeding from the greater palatine artery, and that needs to be cauterized well to have a clean field in the surgery. This incision then is extended onto the anterior wall of the maxilla, and it is extended onto the posterolateral wall of the maxilla, as we can see here. So depending upon the amount of disease or the extent of the disease in the soft tissue or the erosion of the upper alveolus, the upper alveolar cuts are taken. So as we can see in this slide, that usually this is the anterior wall of the maxilla, and the cut usually are taken, if they are taken below the infraorbital foramen, we call them as the infrastructure maxillectomy. Whereas when it goes at the level or above it with the preservation of the orbital plate, we call it the orbital plate maxillectomy. This anterior incision is then extended onto the posterolateral wall of the maxilla, onto the maxillary tuberosity, and then it goes up to the level of the pterygomaxillary fissure. You can see here, these are the pterygoid plates, that maxillary tuberosity. Curved osteotome is engaged into this cut and then the tumor is, and then the maxilla is fractured downwards and medially so as to release it from the suprastructure maxilla. So Pankaj sir, what a resident should be careful of when they are doing this part, especially? What points of caution you would like to tell them?
So surgically, two things you should do. Before you take the osteotomy, you should detach all the soft tissue from that area. Because what happens that unless you have demarcated your cuts and soft tissue has been completely denuded from that area, when you do the cuts, if there is a bleeding, then you are in full control, number one. Number two, most important thing that many people forget is the tube should have been put in the opposite nostril. Because many other times when you are using the reciprocating saw and you go up to the midline, once in a blue moon, you will cut the endotracheal tube also. Or you damage the endotracheal tube, or you cut the cuff, and then suddenly you have an emergency of deflated cuff. So the tube should be on the opposite side. And most important is that, as you rightly said, that when you are taking the cut, the palatal cut and the maxillary cut, it has to be based on the imaging that you see prior to the surgery. If the bone is involved, the palate or the sinus is involved, the height of the cut has to be appropriate, because sometimes when you are doing an infrastructure maxillectomy and suddenly when the disease is creeping along the lateral wall of the maxilla, of the maxillary sinus is involved, then doing the revision surgery is very, very difficult. And third, many a times when the disease in the retromolar trigone, rather than putting your curved osteotome in the pterygomaxillary fissure and taking the osteocut before, I prefer that, as you rightly said, you knock down the entire infrastructure maxillectomy, swing it out, and then take the entire cut along the pterygomaxillary area, all the pterygoid plate, based on the soft tissue extent. Because sometimes in the retromolar trigone area, which is the classical indication for the bite composite resection, the disease has involved the pterygoid plate, and sometimes a good CT scan may also miss it, or sometimes when the CT scan is old, you have missed it. And therefore, that part has to be done under complete visual inspection. And then rather than using the cautery, sometimes I use a strong scissor to take the entire part of the pterygoid plate in the pterygoid maxillary fissure area en bloc with the primary tumor.
Correct, sir. So I think sir has already enumerated all the important points. So going ahead with the presentation. So and then this is an important relationship of internal maxillary artery with the posterolateral wall of the maxilla, and one has to be careful regarding the pterygoid division, the pterygopalatine division, and like we already discussed with Dr. Ashok, the mandibular division of the internal maxillary artery. The various branches needs to be ligated or to be cauterized well while doing this resection. So the tumor was, then the maxilla was fractured downwards, and once we have done that, we can see here the medial pterygoid and the lateral pterygoid muscles. So these, regarding the medial pterygoid muscle, because most of our lesions where we are doing bite resections are retromolar trigonal areas, where there is abutment of the disease either onto the medial pterygoid or the medial pterygoid is involved. In those cases, the medial pterygoid needs to be resected close to the pterygoid plates, as we can see in the second diagram. And the involvement of the lateral pterygoid, mainly the lower fibers, it can be operated with the infratemporal fossa clearance. However, the involvement of the upper fibers, which originate from the base of the skull, that makes the case inoperable. So here we can see, once we cut the medial pterygoid and the lateral pterygoid muscle, we are going to encounter the pterygoid plexus of veins, as we already discussed that these pterygoid plexus of veins lie between the medial and the lateral pterygoid muscle, and the lateral pterygoid and the temporalis muscle. So what are these pterygoid veins? These pterygoid veins are basically valvulus veins, which collect blood from or drain the area of the nose, paranasal sinus, nasopharynx, hard palate, and then they communicate with cavernous sinus. They get the tributaries from ophthalmic veins, facial vein, and connect together to form the maxillary vein, which behind the neck of the mandible and drain into the retromandibular vein. So sometimes these can lead to extensive bleeding in the perioperative and the post-operative period. So Dr. Arvind, what suggestion you would give the residents to tackle with this kind of pterygoid plexus bleeding?
Yeah. No, I think prior to that, I think I also want to reiterate a couple of things. It's very important that we see the imaging properly and sort of plan. I think that's the most important area where you need to do the cuts. And we tend to sort of in a bite resection, we tend to do those cuts initially. So sometimes you can do what is called as a compartmental clearance. Like, it all depends on as you rightly said, on the extent of the disease. If it's a lower fibers of the medial pterygoid is involved, you may not need to sort of go. But if it's a very high involvement, some parts of the lateral pterygoid involvement, then the best is to avoid it. You try to do a sort of an infratemporal fossa formal clearance, detach origin to insertion of the muscles, and then you possibly may want to avoid it. But then again, as I said, it all depends on the extent of the tumor, which you can sort of make out radiologically. And if at all there is some sort of a bleeding, and the best thing is to sort of not avoid putting suction, keep on putting suction, you'll sort of traumatize the area more and more. So the best thing is sort of to have a controlled dissection, and in case you're having some problems, you pack that area. And you sort of, at the end of it, you probably take some stitches later. So I think it's more important to sort of avoid entering the plexus and by doing a sort of a compartmental resection, especially the tumors are going slightly higher up.
Yeah, just to add, Poonam, to your question to Arvind, just give firm pressure for sometimes, and if it not controlled by that, then just to take a figure of 8 kind of thing with the remaining muscles, that is sufficient many a times.
Correct. Even we end up taking most of the time, we say it as a pterygoid stitch, and we take a figure of 8, which causes we buttress the medial and lateral pterygoid muscles so that the pterygoid plexus get sandwiched between the two. Correct, sir. So
even when there is no bleeding, also sometimes at the end of the surgery, the sense there would be some such small ooze, so I sort of irrespective of the bleeding, after the entire thing is done, I tend to take a figure of 8 in almost all patients. Of course, if there is a bleeding, then probably you may take a stitch extra or something. So that's possibly my practice, but I'm sure that there may be a little variation.
Just want to add one thing. You might say, if when we take the upper alveolus, when it open the maxillary sinus, sometimes we take out the mucosa. But when it's just an upper alveolectomy, when just a mucosa left, you have not commented on that.
Sorry, sir, I missed that. Can you please repeat?
No, when we take an upper alveolectomy or infrastructure maxillectomy,
Correct, sir. So I think we can, upper alveolectomy is usually done when the disease is basically in the lateral soft tissue in the upper gingivobuccal sulcus abutting the upper alveolus. In fact, there can be minor erosion or small erosion at the level of the root of the teeth. But the moment we know that the disease is more in the soft tissue, which is going higher along the posterolateral wall of the maxilla, or the tumor is eroding the upper alveolus basically, then at least the cut is going to be just below the level of the infraorbital phenomena. So it is, I think, just about the level at what we are cutting. And like Pankaj sir, Arvind sir, and you rightly said, ultimately it is the proper assessment of the disease on CT scan and the clinical evaluation and taking the cut accordingly.
And
so,
one
Pankaj.
Yeah. So Poonam, basically, for beginners, what is important to understand that you should tackle disarticulating the head only when the tip of the coronoid is released. You have detached all the fibers along the mandible like masseter, then the insertion of the medial pterygoid and lateral pterygoid on the medial side of the mandible. So that means the whole mandible specimen is only hanging on the neck of the mandible now. And that is the most controlled area where you can put some artery forceps along the entire cuff of the tissue that you have around the mandible while you are taking the cut. But the most important thing is that keep hugging the bone. When you are trying to disarticulate, when you are doing segmental, then there is no problem. But when you are disarticulating, keep hugging the bone with coagulating current at least 25 to 30 if you are using the Valley lab. And if you remain that, there will be oozers. Just keep taking the clips, the artery forceps. And once you have disarticulated, you all have very rightly said that even if there is no bleeding, please put pterygoid sutures. The reason is that sometimes under the cauterization or maybe thrombosis, these vessels may close. But eventually, when there is a blood pressure rise or there is, there is a dislodge of the clot, then you can have a torrential hemorrhage later.
Correct, sir. Thank you, sir. So going ahead with the presentation. We have removed this specimen and with adequate margins. I think the mucosa is a bit folded here, so it looks a bit close, but it was good adequate margin here. The tumor, this is the kind of defect which was produced, which was complex, and in our case, we reconstructed the defect with the a PMMC flap. So, sir, your opinions regarding that, what would be the appropriate reconstruction in such cases of wide composite resection?
So if you have done disarticulation and posterior segment mandibulectomy along with the bite composite resection, then in that situation, I would say that there is no skin loss, correct? This is only the bite composite resection without any skin loss. I would not shy from doing a pectoralis major myocutaneous flap, provided the patient is lean and thin and suitable for a PMMC, because I would not do it in a female. I would not do it in someone who is having a bulky chest. So those will be the straight contraindication for pectoralis major myocutaneous flap. And of course, if you are doing a microvascular reconstruction, then there are two options, like people who could do a cantilever and do a fibula. That is also an option. But I would say that in such a defect, even if you do a soft tissue reconstruction like an anterolateral thigh flap, that would suffice.
Yes, sir. Dr. Ashok, your viewpoint?
Same, Poonam. I totally agree with sir.
Sir, Arvind, sir?
Yeah, I think it all depends on how much of the maxillary thing is going. So if you're sort of having to go very high up in the maxilla, and as in some cases you're doing, then you may be sort of inclined to do a microvascular. But otherwise, I think exactly what Dr. Pankaj has said, and invariably, I think it all depends on the volume of the center is there, no? So ideally, you can sort of do microvascular, but then in case you have lot of cases, then about 60 to 70% would be regional flap reconstruction. So that's what I would sort of hazard. And there is no sort of hard and fast rule. It all also depends on the extent of the soft tissue involvement. If the lesion in the maxilla is reaching closer to the midline, or for other reasons which Pankaj had mentioned, elderly lady. So in which cases you may be slightly swayed to sort of doing a microvascular. Otherwise, in a majority of the high volume centers, there is a significant proportion of patients who would have a regional flap in the form of a pectoralis major myocutaneous reconstruction.
So Poonam, one thing is very important here, as Arvind and Ashok rightly said, that if we are away from the midline on the palatal side, PMMC can be sutured to the palatal edge. In case we have crossed the midline, or if we are reaching up to the midline, then if we take the PMMC to form the palate and suture it to the palatal mucosa, then the stoma becomes narrow and the oropharyngeal apertures become narrow. And that is where we can keep the mandible at the PMMC lateral to the maxillary wall, on the lateral maxillary wall. So you have to literally suture it to the with the proline with the lateral wall of the maxilla, rather than bring it to the palate. And for palatal fistula, you have to have an obturator. So this is one area where PMMC, whether to be brought to the palatal edge or remain on the lateral wall of maxilla, has to be taken a decision intraoperative.
Correct, sir. So with this, the take-home message. So again, that a proper intraoral assessment of the disease, clinical evaluation and digital palpation for the skin involvement, assessment of the paramandibular disease with the help of clinical examination and CT scan, then maintaining the good lateral soft tissue margin and appropriate maxillary cut like we discussed all throughout the discussion, and then managing the internal maxillary artery and pterygoid plexus bleeding with appropriate reconstruction is the way to go, and to manage a bite composite resection. With this, I conclude this session. I thank Pankaj sir, Arvind sir, and Dr. Ashok for giving their inputs, and I think it has helped the residents and all of us in understanding the bite composite resections even better. Thank you, sir.
Just one thing which Dushyant very rightly said, that whenever we put mandible PMMC lateral to the mandible, it drops down. So Dushyant, you are right. The surgeon has to take special precaution that they hitch the tip of the mandible, tip of the muscle to the surrounding muscle in the ITF, and also the skin to the bony margin. And that bony margin suturing has to be done with the proline, not with the vicryl. So you are right. I take your point.
Thank you, Dr. Poonam Joshi, for making our budding surgeon understand this complex surgery. And I thank all the experts for the great discussion and giving some surgical tips. Moving ahead with the next session. The session is on reconstructive ladder for oral cancer. The experts for this session are Dr. Dushyant Shankar sir. He is professor and head, Department of Plastic and Reconstructive Surgery, Tata Memorial Hospital, Mumbai. Dr. Dushyant Mandlik sir is a senior consultant, head and neck reconstructive services, HCG Cancer Center, Ahmedabad. The talk is by Dr. Deepak Balasubramaniam. He is Associate Professor, Head and Neck Surgical Oncology, Amrita Institute of Medical Science, Kerala. I request Dr. Balasubramaniam sir to please share his screen.
I'm online, but I'm not able to share the screen. It says you cannot share the screen while the other participant is sharing. So I think somebody else is sharing their screen now. So
yes, sir.
The organizers.
Share the screen now.
Yeah. So can you see the screen now?
We are able to see the screen.
Yeah. So I thank the organizers, Poonam, and all the other consultants in Tata for giving me the opportunity to present both the reconstruction. This is, in my opinion, the most exciting thing about oral cavity tumors, because resections lead to a defect, and then the defect needs a reconstruction. And I think that this is something that is very exciting. I have two parts of this presentation. One presentation in 10 minutes will be the options that we have in oral cavity carcinoma, and the next 10 minutes will be case-based discussion. So we'll start so that we don't waste time. We're already about half an hour away from our time limit. So let me start my resection. So what are the considerations in oral cavity resections? We have a loss of mucosa. We have loss of muscle. So mucosa can be tongue, buccal mucosa. Loss of muscle can be the intrinsic muscles of the tongue, extrinsic muscles of the tongue. Loss of bone can be loss of mandible, either partial or complete. And there's a loss of skin if the tumor extends from the buccal mucosa to the skin. So how do you replace that? So the loss of mucosa, you need pliable tissue. If you have loss of muscle, like in the tongue where there's intrinsic and extrinsic loss, you need pliable tissue with bulk. If you have loss of bone, you need bone with skin cover to overlay the bone that you have put inside the oral cavity. And if there's loss of skin, you need a skin-lined flap. Now, the unfortunate thing is that in the reconstructive ladder, like this reconstructive ladder has been described for all secondary defects of skin loss or muscle loss in extremities and in the trunk. Unfortunately, none of the other techniques except for free tissue transfer and local tissue transfer work for oral cavity. Skin grafts, collagen sheets, and whatever that you try to put does not work for the oral cavity. And the only options that you have are free tissue transfer and local tissue transfer. So let's say you have a defect like this in the tongue. It's a hemiglossectomy. We have resected the right lateral border of tongue. The patient has probably a defect that does not require reconstruction, but this is what happens to him in the end. So size never matters. There's always fibrosis from secondary healing. Never imagine that a 1/3 defect need not be reconstructed. If you have defects that are extending to the floor of mouth, you always have to put pliable tissue there. Otherwise, the tongue will end up like this. There is no tip movement, there is no lateral border movement, and the patient is going to suffer for the rest of his life. So ideal tongue reconstruction, we need bulk. First of all, that is the most important thing that you need to remember. If you're doing a partial glossectomy, you need a pliable tissue, but if you're doing a subtotal or a total glossectomy, you need sufficient bulk that has contact with the palate. You need to create a shelf which is superior to the laryngeal inlet to guide the bolus into the hypopharynx. You need pliable tissue that uses the contralateral tongue for its movement. And if you can provide muscle. I have done tug flaps, ALT, which is neurotized, which can give some movement to the tongue, which might not be significant, but it does help with the swallowing. And if you have an associated sensory nerve, like the antebrachial nerve in the forearm, or if you any other sensory nerves, you can use it for neurotizing the tongue, the neo tongue for sensory innovation. So the choice of flaps, if you resect a tongue tumor, the primary choice is a faciocutaneous flap. That can be a radial forearm, a lateral arm flap, or an ALT flap. How do you decide between these? You need to consider the body habitus and the amount of volume that you need to reconstruct. And you also have to keep in mind the donor site. You cannot leave a worse donor site defect in the patient compared to the primary defect site and then call it a successful reconstruction. We always have to consider the donor site. And then in your inset, when you resect, take the flap and then put it in the primary site, you have to avoid insensate gutters, good palatoglossal seal, tight closures in the floor of mouth, maintain the shape of the tongue and don't distort the tip with the inset. So if you look at a sagittal section of the tongue, you have the mucosa and the intrinsic muscles on top. Then you have the extrinsic muscles in an intermediate layer. And then you have the floor of mouth muscles at the depth. So when you reconstruct the tongue, you have to reconstruct these different layers. Often it's not possible, but we try to reconstruct the mucosa and the bulk of the intrinsic muscles and then reconstruct the floor of mouth after that. So radial forearm flap based on the radial artery, venae commitans, and the cephalic is still the workhorse flap for the oral tongue carcinoma. I'm starting with the free flaps first because I still feel that in a normal patient, this is the gold standard unless the patient has cardiac or other debilitating comorbidities. I still think that this is the most important flap that you can use for the tongue. It is skin lined, I agree. There is hair. It doesn't secrete, it doesn't mucosalize that easily, but this is still the gold standard. The reason why I don't like the radial forearm is that the donor site has to be skin grafted, so I prefer the lateral arm flap. It's from the arm based on the PRCA, has good bulk, it's relatively hairless, and then the primary site can be closed primarily as you see in this patient, and it tends to mucosalize quite easily as well. Now, there are other donor sites that we can take. This is a patient that had a compartment excision of the right lateral tongue with the level 1A and 1B nodes. We raised a MSAP flap from the calf. This skin is quite thin. There's no hair. It's the vessels are quite thin, which we need to take into consideration before we do the anastomosis. But this is another hidden site. The other flap that is commonly used for tongue is the anterolateral thigh flap. You can see that this flap is quite thick because different people have different thickness of the subcutaneous tissue in their thighs. So this is a thick flap, but you can see how much that the thickness can be removed, and this can be made a very thin flap. So this is a boutique flap. This is what I learned from Australia. Any defect in the head and neck that requires mucosa or skin can be reconstructed with an ALT, provided that you do adequate thinning of the flap. Now, when you don't have to do thinning, when there's a massive glossectomy, you need a flap that can give tongue bulk, that can go to the floor of the mouth, and that can go to the tonsil. Because when you do a mandibulotomy and try to resect the tumor, you would resect the tongue, floor of mouth, tonsil, lingual sulcus, and part of the tonsil. So you can quite easily contour a tongue flap from an ALT. And this is how you suture the ALT to the tonsil. This is how you put the fat in the dead space. And this is how you suture the remaining tongue. And then we have a good protuberant tongue. This is most important because good palatal contact is essential for good tongue reconstruction, and it's protuberant and aesthetically it's acceptable. In due course, this patient will have mucosalization of the ALT flap. And this is what the flap looks like after 3 months. This is 6 months, and then you can see the patient had a bit of posterior tongue, but you can see that the flap has held its bulk quite well even after the radiation. Now, one of the things that you have to consider, especially in tongue reconstruction, is that how much ever you fill the volume of the tongue, radiation is going to cause shrinkage. And this is what happens to an ALT that was protuberant after surgery. This is a few months after radiation, and this is a year after radiation. So you can see that the tongue has shrunken quite a bit. There is no palatal contact. There is no way that this patient is going to be able to propel a bolus of food by having a glossopalatal press into the oropharynx. So these patients are quite crippled, and we have to remember that whatever happens, we have to stabilize the reconstructed tongue. Now, one of the flaps that I've really liked in the recent past is to do a tuck flap, that is a transverse upper gracilis flap. It's from the medial thigh. The skin paddle is oriented on the gracilis muscle. You have the obturator nerve, which you can anastomose to the hypoglossal nerve. And then you have the vascular anastomosis. And this muscle serves to reconstruct the oral diaphragm, which prevents the tongue from sagging and prevents the tongue from not having a palatal contact. And even in a large surgery, like this patient who had a laryngectomy and a glossectomy, it does not matter really. If you plan a pedicle flap, you can do a pec major and still give a protuberant tongue for the patient to be able to swallow post-op. And this is one of the things that I'd like to state to all the viewers. If you take an ALT flap, you have to reconstruct the oral diaphragm by suturing the fascia lata to the mandible by drilling holes and taking proline stitches. And this is a technique that prevents the sagging of the ALT flap into the neck. And this is a picture of where the fascia lata has been sutured. So the ultimate aim is not only reconstruct the tongue in a large tongue defect, but also to reconstruct the floor of mouth. Now, coming to some local flaps, we have a choice. We have multiple choices: submental, infraoid, nasolabial. The submental is a good flap because it's got thin skin. It's good in female patients who are debilitated, who cannot take a free flap for their reconstruction. Unfortunately, The oncological safety is quite suspect. We have data from RCC saying that it's a good flap to use for oral cavity and buccal carcinomas. But you got to remember that level 1A fat has to be removed from the flap. And if it's a male patient, they've got hair, and that hair is quite debilitating. Now, the submental flap can be raised as a straightforward submental flap or a flap that is reverse based on the facial connections. Either way, the skin island remains the same. The advantages and disadvantages remain the same. This is a flap that I quite like. It's the infrahyoid flap based on the perforators from the superior thyroid artery and vein. It's good for tongue defects, floor of mouth. It's quite hard to reach the tongue sometimes, but you can use it for a multitude of defects in the oral cavity. Mandible, marginal mandibulectomy, floor of mouth, tongue, this is quite okay, but anything higher doesn't really work. And this is another flap, which is a modification from the standard nasolabial. The standard nasolabial can be either an axial flap or a random flap, but I prefer to harvest it as a flap that is based on the facial artery and facial vein. Take it to the neck, tunnel it to the oral cavity, and use it to close tongue defects. And this is another flap that is quite commonly used, that is the FAM flap, again based on the facial artery and facial vein. The advantage of this flap is that you replace like with like. When you remove tongue mucosa, you replace it with tongue mucosa and the buccinator muscle underneath. So it's secretory, it's sensate, it's got a lot of advantages. But the only problem is that the cheek donor side defect is quite bad. So if you have a glossectomy defect, if you have a lateral border tongue defect, you have to preserve mobility and the flap has to be lax. If you have an anterior two-third defect that is complete, you need a folded free flap and you have to do flap anchoring to the mandible. Subtotal and total, you've got to use flaps that will replenish the bulk, and you've got to recreate the oral diaphragm. So the choices that we have, lateral arm, lateral tongue, if you want to do a local flap, submental, FAM and infrahyoid are quite okay. If you want to tongue with floor, a FAM islanded FAM is also fine. A nasolabial flap is also okay. You can do a nasolabial pedicle flap if the patient has no teeth. Otherwise, you can make it an islanded flap. If you have intact suprahyoid musculature and base of tongue, you can do a pec major. If you don't have suprahyoid musculature or base of tongue, you can still use the pec major. But now look at buccal mucosa defects. If you have a buccal mucosa defect that is does not involve the skin, you just need to have pliable tissue that replaces the loss of buccal mucosa. So the picture on the left is a radial forearm flap. The picture on the right is a buccal pad fat. So the difference between the two is that it depends upon the level of your excision. The buccal fat pad is quite big. If you can pull it from the zygoma downwards, it offers a lot of tissue, but you've got to preserve the buccal artery. If you resect the buccal artery or bipolar the buccal artery, the buccal fat pad does not work. And in most instances, this fat pad will heal by secondary intention, meaning there'll be scarring and difficulty in opening the mouth. And that is why I still prefer to use a radial forearm flap. And if you have a large defect like this is an angle split with a marginal mandibulectomy and a buccal mucosa defect, I still think the radial forearm flap is the best flap that we can use. If you have an extensive buccal mucosa defect where you have resected the posterior maxilla, gone to the infratemporal fossa, cleared all the way to the skull base, there's a choice between putting bone or putting soft tissue. I still think soft tissue is better because you can fill the infratemporal fossa, and with an ALT, you can get quite good cosmesis, especially if there is bulk. And considering the disease, I think ALT is still a better flap. And if you have a defect that involves skin and the mandible, I still think an ALT with a filler with the vastus lateralis is a good flap. So I would still think that these patients would benefit from an ALT flap. But if the patient is debilitated, cannot take a free flap, I would consider a pectoralis major, which is folded for the external skin. It's quite difficult, especially in patients who have a bulk, subcutaneous tissue and all of that, but we have no choice. It all depends on how you mark the pec major and how you capture the bulk of the muscle, but you can still use a pec major for that. And I still think assessment is everything. This was a patient that presented to us who had an exophatic tumor, which was through and through. And we thought that we have to excise a lot of primary tissue. But in the end, the excision was small with adequate margins, and the patient had an ALT flap, and he's still doing well after the surgery and post-op chemoradiation. So buccal mucosa carcinomas, divide them between less than 2, more than 2 centimeters, and through defects. So less than 2, you can use local buccal fat or second intention. More than 2 centimeters, use a radial forearm. If it's through and through defect, you have to look at whether the commissure was involved or the commissure was not involved, and then look at other flap choices after that. So last, I just want to look at the different sorts of bone reconstructions that we do. If the patient has a segmental defect, which is amenable for bone reconstruction, meaning there is a proximal segment, the condyle coronoid is available for plating. The patient doesn't have too bad skull-based tumors. You have a variety of flaps, and this is the best thing to do to restore the occlusion, especially if it's a young patient who's dentate. So the first picture is a fibula flap. The second picture is a DCI that I had done. DCI allows you to contour the bone all the way to the ascending ramus. And the third patient had a scapular flap from the shoulder, and this also allows for good bone reconstruction. But fibula is still the workhorse because it's got dual blood supply, long bone and pedicle, good bone stock, good skin paddle. The donor site is quite acceptable. We can use a 2-team approach for this. We can contour the bone, osteotomize it for the defect, and we have good sized vessels for the anastomosis. So in the end, replace like with like. Free-flap reconstruction is still the gold standard as far as I'm concerned. Return of form and function is key. Donor site morbidity is to be minimized. Don't burn your bridges. If you raise a pec major for a patient from the ipsilateral side for a defect and he has a recurrence, you cannot do anything. It's quite easy to raise the pec major and then fill up a defect, but if the patient has a recurrence, you would have burnt all your bridges. And always be prepared for failures, either a local flap or a free flap. Always have plan B. So are the panelists available now?
Yes, Deepak, good evening.
Good evening, sir. Good evening. So I'll just run through these few cases quickly. So this is a lateral tongue defect in a relatively young patient who's got good dentition. It's a female patient. What are your local flap options? Free flap we have discussed. What are your local flap options for this defect?
So for a tongue defect, if it is very small, maybe buccal mucosa is one option, or a FAM flap, as you can say.
Okay, sir. But for the FAM flap, what precautions would you advise your oncologist to do?
There are two things. Point number one, that when we are doing a FAM flap, obviously, if we are tunneling it through below the mandible and then taking it inside, then we'll have to reroute it in that case. So if we are doing that, then obviously neck dissection has to be, we have to see whether the vessels are fine or not according to the neck dissection thing. Otherwise, even a random pattern buccal mucosa flap can be used just to on the lateral aspect of the tongue, and it can be a posteriorly based flap and can be delivered from the retromolar region in this kind of a defect if there is not submucous fibrosis.
Okay, sir. So for the audience, remember that the fan flap can be islanded flap through the floor of mouth, or if you can turn the flap from the retromolar trigone, you can still be able to reconstruct this defect. Dushant, any other flap that you would like to use for this?
Deepak, I have personally not used it much, but I think the infrared flap is also a good option nowadays. I think with your series and few of them are doing it, infrared can be also one of the good option. I'll be wary of using a submental with this much of a tongue lesion at level, maybe harboring 1B lymph nodes, but infrared can be thought of.
Okay. So, sir and Dush, would you consider the nasolabial for this at all? I know submental is out of the question for oncology.
Nasolabial, I don't think is going to be a very comfortable reach for this kind of a defect, because the teeth will come to reach to the tip. Actually, frankly speaking, I have never considered a nasolabial like this.
Deepak,
I would generally err on the side of either doing a radial or maybe a buccal mucosa flap, but mostly we go ahead with the radial.
Deepak, I think she is a young female where there is not a prominent nasolabial skin. So that can give a bad scar to a female on the face. So I will like to avoid it.
Okay. So for the trainees here, you have a lateral tongue defect. Please take into consideration the age, the sex, and the habitus of the patient. As sir mentioned, if you want to have a local flap in such cases, try the buccal mucosa as a donor site. And as Dushan mentioned, try the infrahyoid as a donor site. Don't violate the face. If you don't have any of these options, consider radial forearm, because the defect is quite big and it's a young patient, so you don't want to make any scars in the area of the face or the neck. So this is a buccal mucosa lesion. I'll ask sir first. This was a superficial lesion that has been excised. Buccinator was excised, but the subcutaneous fat was still preserved. And this was the extent of the lesion, not extending to the upper gingival buccal sulcus, but extending towards the lower teeth. So, sir, how would you like to resurface this defect?
Deepak, what would be approximate size of the defect? Let's say 6x4 or 6x5.
Yes, sir. 5x4, 6x4. Yes, sir.
Again, for us, the choice would be a thin soft tissue flap. Now, thin soft tissue flap, we can choose from a lot of things, like a thinned flap if the thigh is thin, even a thin ALT flap. But I would say for a beginner, and most of the cases, a radial artery forearm flap can be a good option, because any thick flap will make the oral cavity very small and may not be a good idea, because no bone is removed. No, in this?
No, sir. It's only
then we require a thin flap. Again, now submental flap, obviously, if you all want to discuss about it, we can always talk about a submental flap if post-op radiation is given, if the neck nodes are not, if the facial artery and the submental vessels are okay, a submental flap, yes. Otherwise, all these flaps, even people do supraclavicular flap and all the. Sometimes the problem in those flaps is that the tip necrosis is very common in most of those flaps. Yeah. So I would personally prefer to do a thin soft tissue flap in this, a free flap.
Yes, sir, if the patient is old and cannot take a free flap, would you consider skin grafting this lesion or applying collagen?
See, it would be a trade, or I would say it would not be as good an option as a soft tissue flap. The reason, we all know that post radiation and there would be a lot of contracture that will happen if you put in a skin graft. But yes, if nothing else is there, and if we have to put in a skin graft would be okay. But as you were saying, the cheek muscles are also gone, knowing this. So
yes,
so then in that case, putting a skin graft, I would not say I would prefer that. Because even if a patient is old, still.
Yeah. So what sir is trying to say is that the surface area and the depth of excision is important, and the logic of providing pliable tissue is really important here, because such a large defect can only be reconstructed by a radial forearm flap, because none of the local flaps have the surface area to reconstruct. Dushan, do you have any opinions about this?
Yes, Deepak. I will also like to know which type of lesion we have excised. To me, it looks like it was more kind of a varicoid lesion with less of a
Correct.
depth,
Correct.
right? And you have saved a lot of muscle. Only at the base you have removed the muscle.
Yeah.
Right. If there are situations which will not allow me to use pre-flap, I will not hesitate from putting a STG also. Most probably likely that this patient may not receive radiation the way you are, seeing the disease.
Okay.
So
So
it's not a
this
bad
is a
option.
very this is a very, very important fact that Dushyant has said. This is very relevant for the trainees. It depends on the type of lesion that you have excised and the depth that you've excised to. And if this is a patient that is not going to receive radiation, because truthfully, this is going to be a defect for a FAM flap. If the subcutaneous hasn't been excised, or it's going to be a defect like harvest of a FAM flap, and we leave those defects to heal by secondary intention. But the important thing to remember is that if the patient has trismus because of submucous fibrosis on the opposite side, then don't allow these tissues to heal by secondary intention or a graft. Please put a soft pliable free flap that is important, which will allow for mouth opening and things like that. Now, this is a patient with a marginal mandibulectomy and a buccal mucosa excision. Sir, apart from radial forearm, which I had already shown a picture, how else will you resurface the bone and provide mucosal cover for the buccal mucosa?
So in this, Deepak, as I can see, point number one, that radial artery forearm flap, is the outside skin also gone?
No, sir. Skin is fine, sir.
Skin is fine. So because there has been a removal of a lot of mandible, marginal mandible has been done. So there will be a lot of cavity and space there inside. So what
Yes,
I can
sir.
say is that here even a slightly thicker flap may be okay to fill in the cavity. So radial artery forearm flap may not be required. If the thigh is thin, we would prefer probably a soft tissue flap, if at all, would be an ALT flap. Now, having said that, if it is a bone and if there is very small amount of bone left, people may also prefer to do a bone flap, not for the entire extent. Even doing a fibula for the entire extent will not be required, because you only require to augment the bone where osseointegrated implants may be required, which can be in the anterior part. So it can be both these things.
So the point that sir mentioned is important. You have to assess the residual bone that you have. If you have a patient who has got a benign tumor or a patient who's got good prognosis, you might want to augment the bone height in the initial surgery itself. So the first option to augment the bone height is obviously a fibular flap. If you don't want to augment the bone height and you have a lot of soft tissue deficit, then a thin ALT also is a good option, because the radial forearm is just going to sit on the bone and will not offer any contour or anything. So that's a very good point that sir made. Dush, what is your thought on this?
Yes, Deepak. So here our goal of reconstruction is to provide the buccal mucosa and to cover the bone, both. We can't leave it open also. At the same time, we need to provide certain volume to the posterior part of the defect. Maybe probably vertical ramus has been shaved off, maybe.
Correct.
Yeah.
Upper alveolectomy also. The posterior tooth also has been removed.
Posterior tooth has also been removed. So I will also like to see that if we are not able to use a free flap, and if the patient habitus is good and it's a thin PMMC flap, I will not hesitate to put a PMMC flap also after doing a good tunneling around the mandible, so my PMMC doesn't get compressed. There is no harm putting my PMMC over the mandible, and it will reach fine. I will have to do certain maneuvers to make it kind of adequately off length, but I think it's not a bad option, absolutely, given the choice. An ALT and maybe an fabricated ALT with thinned out anterior part is the adequate option, but even a good PMMC will give a good reconstruction.
So the trainees, please remember this. Dushan mentioned 2 points. One is the habitus of the patient. If the patient is not fit for free flaps, the habitus decides whether you use the pec major. And the second is careful tunneling lateral to the mandible and then insetting the pec major over the marginal mandibulectomy into the floor of mouth and the upper alveolus. So you are not limited only to free flaps. You also have the pec major for you to do that. I have done supraclaviculars for this, but the problem with supraclaviculars, as Sir mentioned and Dush mentioned, is that the tip necrosis can't really be predicted. The same thing with the deltopectoral. So when the blood supply becomes random, you really can't predict it. So I'd like to end with this. This is a segmental mandibulectomy defect. Patient is dentate, young patient, and not bad skull base disease. So, sir, would you consider bone reconstruction in such a young patient, or would you just opt for a soft tissue reconstruction?
Now, Deepak, since you are asking this question, this has always been a point of debate in all the panels I've ever been in. What I would say is, see, as I can understand, there is no posterior ramus or any part of the posterior part of the mandible that is left on the left side. It's almost
nothing, sir.
Nothing is left. So entire condyle, everything has been.
The condyle, the part of the condyle just below the
very
neck
small part of the condyle is left.
Yeah,
right.
We can now put one screw there.
Correct. So what I would say is, if we consider it functionally, even doing a fibula flap, the patient will not be able to chew from this side, even if let us assume that the entire fibula survives and we are able to put in osseointegrated, because all the muscles, the masticator muscles and all the muscles of mastication have been removed from the left side. So
this is an extremely important point, sir.
Yeah. So this will, the patient will not be able to chew from the side. But at the same time, if suppose there is a useful segment on the left side that is left, there is absolutely no debate we should use a fibula. In this situation, generally people will say that even a soft tissue flap will give almost equal results because the arch is preserved. However, there are papers and there are many people who are of the opinion that if we do a fibula, the deviation of the remaining mandible is less because the skeletal framework, whatever it is, it doesn't allow the fibula or the contracture of the soft tissue doesn't allow the mandible to tilt as much if a bone is removed. A bone is used for reconstruction. So if there is a hard bone which is present, the tilt of the mandible of the remaining mandible is less. So the remaining mandible may be more useful. Now, having said that, in our practice in Tata Hospital, majority of the times for such defects, we may do either a soft tissue flap, which can be an ALT if suppose it's a female or otherwise even a PMMC flap. Most of the high volume centers will probably do, because a middle third may be a more appropriate post for a fibula. This is what I would answer with that.
So to all the trainees, sir mentioned two very important things. One is the availability of the proximal segment of the resected mandible. And second, if you do a bone reconstruction without even a proximal mandibular segment, you avoid the occlusal cant or you avoid the drift of the native mandible this side. But again, you've got to remember the patient cannot chew on that side because there is no opposing teeth. You might reconstruct the aesthesis, but functionally the patient might not have a very good result unless there is a proximal segment of the mandible that is still left. Dush, I just last question to you. I think we are running short of time. What would be your choice of flap?
Deepak, I will agree with Dr. Vinay's comments, but at the same time, I will like to add the patient has good mouth opening, and if you are not reconstructing with a bone, at least fabricate a bite guide pre-operatively.
Oh,
so
very
the
good.
residual mandible takes good function.
Yeah, so you won't have a bite guide so that the patients. So how long do you think this bite guide needs to be put? Because you can't put a bite guide without. Yeah.
Sir, we are late by half an hour, sir. We need to conclude this program.
Yeah. So I'll end now. So Dush, thanks, and Vinay sir, thank you so much. I thank the organizers for everything.
Thank you.
We'll
Vineet.
take any questions if you guys don't know.
So can you please stop the screen sharing?
I think I did.
Yes, sir.
I think I did.
Yes, sir. Yes, sir.
Quite late, I think.
Thank you, Dr. Deepak Balasubramanian sir, for his excellent talk on reconstruction. And I also thank our expert, Dr. Vinaykanth Shankdar sir and Dr. Dushyant Mandik sir for their valuable comments. Now coming to the next session, histopathological risk stratification in oral cancer. The experts for this session are Dr. Munita Bal ma'am. She is Professor, Department of Pathology, Tata Memorial Hospital, Mumbai. Dr. Saurav Datta, he is Consultant, Head and Neck Surgical Oncology, Medical Super Speciality Hospital, Kolkata. The talk is by Dr. Asavari Patil ma'am. She is Professor, Department of Pathology, Tata Memorial Hospital, Mumbai. I would request Asavari ma'am to please share her screen.
I cannot. Hi, good evening, everyone. I
Yes,
cannot
ma'am.
share my screen yet.
Ma'am, I am just logging out. Ma'am, please share the screen, ma'am.
Okay.
Stop share, right?
So, good evening, everyone. I would like to thank Poonam and her team for giving me this opportunity to discuss histopathological risk factors with all our PG students. Yes, now I can share my screen. So, now from surgery, we are changing it to histopathology, and we are going to discuss some of the factors that can affect the treatment in oral cancer patients. So, first of all, what is risk stratification? This is a process of quantifying probability of a harmful effect to individuals resulting from range of internal or external factors. Now, here we have to differentiate risk stratification from healthcare needs. Risk stratification implies some event that is going to happen in future, while healthcare needs, that is something as a capacity to benefit from healthcare, and it is actually needed at the time of assessment. And both risk stratification and healthcare needs are required for the management of cancer patients. So, how risk stratification is helpful? It can help in planning the treatment to avoid over or under treatment. It also initiates better communication between clinicians in different modalities. Of course, it allows better allocation of the resources, and it involves patients. So there will be shared decision between patients and clinicians. Patient can understand the morbidity, etc. Now, when we talk about treatment of any cancer, or if we come to oral cancers, the factors are broadly divided into tumor factors and patient factors. And today I'm going to discuss mainly the tumor factors, which majority of the factors are histopathologically decided. And these tumor factors usually include tumor stage, and then which includes T and nodal stage. There are other histopathological factors like grade, PNI, LV, etc. Then tumor location or site is important, distant metastasis. So all of us, we are familiar with this HSCC cancer staging, which is the foundation of risk stratification in oral cancer and helpful in deciding the treatment. And currently we are using 8th edition. And let's look at some of the parameters that are helpful in deciding T and N stage in oral cancer. Here I'm talking about oral squamous cell carcinoma, which is a commonest type of cancer. Almost more than 90% of cases are of squamous cell carcinoma. So when we consider the T stage, the important parameters are tumor size, depth of invasion, and advanced tumor or tumor extent. And cutoffs for tumor size are 2 centimeter and 4 centimeter. For depth of invasion, it is 5 millimeter, 10 millimeter. When we think about, or when we discuss the tumor extent, it is the invasion of tumor into adjacent organs, which include bone, skin, maxillary sinus, masticator space, etc. Now, when we decide end stage, there are following parameters that we are going to include. One is number of metastatic nodes, and usually here it is single versus multiple. Again, laterality, ipsilateral versus contralateral. Size of the metastatic node. Now, the cutoff here is 3 centimeter and 6 centimeter, and extranodal extension, which is present versus absent. Now, we are familiar with, again, this T staging. I just want to focus on this few cutoffs, like T1, the tumor should be equal to or less than 2 centimeter, and DOI should not be more than 5 millimeter. For T2, there are two options given. For less than 4 centimeter tumors, the DOI should be less than 10, but for less than 2 centimeter tumor, DOI up to 10 millimeter is allowed. So similarly, if you go to locally advanced tumor, 4A will be either DOI more than it is more than 10 millimeter, and tumor invading adjacent structures like cortical bone, skin, and maxillary sinus. Any involvement of masticator space, pterygoid plate, skull base, etc. is going to be very advanced disease, and this is usually decided clinically or radiologically mainly. Histopathology doesn't help most of these cases in 4B. Now, N criteria, there are clinical and pathological N criteria. Again, here we have to focus on the cutoffs, which is 3 centimeters, 6 centimeters, and there is ENE negative versus ENE present. Now, for clinical end stage, any clinically overt in ENE in any nodes, ipsilateral, contralateral, any number of nodes, everything is put into category 3B. But when you come to pathological end stage, it is the metastasis to single ipsilateral node, which is not more than 3 centimeters, showing ENE plus, is 2A and 2A. Any other or more lymph nodes or contralateral lymph nodes showing ENE will be considered as N3B. So this way, there are multiple cutoffs and other parameters which we have to consider when we think about tumor and end stage. Now let's look at all these important parameters one by one. When we come to tumor size, which is an essential or parameter or core element, as we say in minimal data set, it is the maximum tumor dimension which is important. Now, we always give 3 dimensions, but maximum tumor dimension is essential. Other 2 dimensions are desirable. When it comes to preoperative T stage, you always assess it clinically or radiologically. But when we document this pathological T stage, the initial assessment is on gross examination. But in case of small tumors, if microscopic dimension, it differs from the gross dimension, then the microscopic dimension supersedes and it is used for accurate assessment of T stage. So this is how one of the hemiglossectomy specimens you can see here. There are 2 dimensions we are measuring, and as we cut here, this is the entire thing is the thickness of the tumor is going to be the 3rd dimension. Coming to the next parameter, which is depth of invasion. Now, depth of invasion and tumor thickness, these are 2 different parameters. Depth of invasion is better assessed on microscopy, and it is the distance from the basement membrane of the mucosa to the deepest point of invasion of tumor, which is best assessed on microscopy and not grossly. This predicts recurrence and nodal involvement in especially early stage tumors. Now, tumor thickness is usually we are assessing it on gross examination, and it is the distance measured from superficial most part of the tumor to the deepest point. So just to explain it further, this is an exophytic tumor. If you see from A to B, this is the tumor thickness. Now, basement membrane is the level of basement membrane is indicated by this yellow line. And if you draw a plumb line to the deepest point, this white line indicates the depth of invasion. So depth of invasion is not necessarily going to be equal to thickness. Most of the times it is less than the thickness. This is one of our tumor sections. Here you can see that the black line indicates the level of basement membrane, while the orange line indicates the plumb line going up to the deepest point. And this distance from black line to the tip of arrow is going to be the depth of invasion. This we can always measure it on microscopy. It is possible to measure it on microscopy. Now coming to the next parameter, which is involvement of adjacent organs. Now, when we say adjacent organs, histopathologically commonest organs we describe is bone and skin, which can be assessed clinically and radiologically also. But on histopathology, we confirmed it on gross examination, but the gold standard is always a microscopy. Here, one thing we have to remember when we talk about the bone involvement, it is the medullary bone involvement that needs to be distinguished from superficial cortical erosion, because medullary bone invasion is an independent predictor of recurrence and poor prognosis. Now, rest of the spaces like masticator space and pterygoid plates, etc., the involvement of these spaces usually done radiology-wise. And if you give us tissue from that area, microscopically we can confirm it. But if in a specimen, we will not be able to identify this area specifically. This is just one of our cases showing a tumor within the bony trabecule. It is the medullary involvement of the bone by the tumor. Now coming to the nodal metastasis. Now besides clinical and radiological assessment, again the gold standard is histopathological assessment. In pathology, all excised nodes that you give us, they are all of them are sampled carefully. And the essential parameters that we have to specify when we talk about the nodal metastasis, in the report, we have to give the total number of metastatic node which is required. If desirable is total number of nodes sampled. Like they could be more nodes sampled, but metastatic maybe few of them. Again, ENE present versus absent, which is essential or core data element. And ENE is considered positive irrespective of size of ENE at present. Now, when it comes to size of ENE, it is further classified into major and minor ENE, depending on size of the ENE. If it is 2 millimeters or less from the capsule, it is minor ENE. Any ENE more than 2 millimeters when measured from the lymph node capsule is going to be major ENE. At present, it is not mandatory to give the distance or the size of the ENE, whether it is minor or major, but it is desirable. And in our reports, we are usually giving the size of maximum ENE. Now, these are some of our photographs showing this is a node with a central portion of this metastasis, and the capsule is nicely seen, and there is no ENE. This is ENE negative. While this is another node, which you can see, this is the nodal periphery, and there is this tumor going outside the node. This is called as ENE positive, and we can measure this distance on microscopy. So besides now this tumor and nodal parameters, there are many other essential parameters which are part of the minimal data sets, and these include tumor locations, margins of the resected specimen, patterns of invasion, histological tumor type and grade, perineural invasion, LVI. There are certain other parameters like tumor burden, tumor stroma ratio, lymph node ratio, which are not mandatory. They may or may not be included. There are still studies being published and maybe will be going on. So coming to tumor site and location, we know there are multiple subsites in oral cavity, and there are various studies. They are discussing the survival and other parameters at different subsites. Notably, these are our two studies from our institute. One is by Murthy and his team, who noted worse loco-regional control and DFS in tongue and floor of mouth cancers. And Dr. Sudhir Nair and his team noted significant differences in tongue and buccal mucosa subsites related to age of presentation and grade and PNI. So tumor site and location has to be specified with the epicenter of the tumor, where exactly it is located. Margins of resection, and which is they are usually reported as free, negative, or close. For close, the cutoff usually used is 5 millimeter, or there can be involved margins. Now, any case which is treated with surgery as a primary treatment modality, the main goal is to achieve negative resection margin, because negative margins are associated with reduced risk of recurrence and longer survival. While positive or involved or close margins are strongly associated with risk of recurrence, overall mortality, disease-specific mortality, and there are some meta-analysis confirming these parameters. So this is one of our specimens sent from head and neck surgery, which is usually oriented with the stitches, and the orientation, especially for wide excision specimen, is essential, because once we get this specimen, we need to be able to understand which is the anterior margin, which is the posterior margin, and so on. So usually we submit 4 mucosal margins and soft tissue margin, which is going to be a base. If there is bone associated with the, or bone is also resected, we'll also submit the bony resection margins. Distance of the margins is always given on gross examination, but we always confirm all these margins if they are negative or not on microscopy. So the closest margin usually, which is highlighted in the report. So this is again just to show you an example of margin. You can see this is a mucosa, the tumor is here, and if you see at the bottom of this section, there is blackish ink, and this is the base. And here we can measure the distance of the tumor from the base and indicate that this margin is completely free from the tumor. Now, there are certain other histological parameters, including tumor type. There are multiple types of tumors in oral cancer, and we are discussing now squamous cell carcinoma and its variants. And there are many variants of squamous cell carcinoma, of which verrucous is very, very well differentiated. Again, papillary carcinomas, they have better prognosis. But there are other variants like basaloid and sarcomatoid and adenosquamous. They have worse prognosis. These are aggressive tumors when compared with the conventional squamous cell carcinoma. Again, histological tumor grade, you know that for squamous cell carcinoma, there are 3 tumor grades, well, moderate, and poor. Variants of squamous cell carcinoma need not be graded because the name itself indicates the behavior. Histological tumor grade alone does not correlate with the prognosis, but it is recommended as an essential core parameter in minimal data set reporting still now. And there are certain studies which are showing some differences in the or some significant associations, although it is the histological tumor grade with other parameters which relates more with the survival and DFS, not the grade alone. Now coming to the pattern of invasion, there are multiple grading systems. Initially, it was Bryan's grading system from describing pattern of invasion 1 to 4, but now there are 5 patterns described by Brandwin Gensler. And this is the worst pattern of invasion, which is important, which is WPOF5, is shown to be significantly predictive of loco-regional recurrence and disease-free survival, especially in early stage cancer. So in a pathology report, we always note down the patterns of invasion as predominant pattern of invasion and worst pattern of invasion. And this is an example of worst pattern of invasion. The bigger this black line indicates the tumor invasive front, and there is another tumor nest away from the main tumor, and this distance is more than 1 millimeter. So this is worst pattern of invasion 5. Perineural invasion equally important, and this is an independent prognostic factors regardless of size of nerve involved. It is significantly associated with poor OS and loco-regional recurrence. It is an essential parameter to be recorded, but in addition to that, we can also specify intratumoral versus extratumoral and size of largest nerve involved, but these are not essential parameters. So this is example of PNI, tumor going inside the nerve or inside the layers of the nerves, or maybe in this case, tumor is hugging around the nerve. Then next parameter is lymphovascular invasion. It indicates presence of tumor in endothelial line space. It should be differentiated from other artifacts. Now, distinction between venous channels and small lymph factors is not required at present. And LVI is a relatively weak predictor of nodal metastasis, but still it is considered as a marker associated with poor prognosis. Level of evidence is low, and in spite of that, we are still including it as a core parameter or essential parameter. Now, there are certain non-core parameters, or they are not mandatory, and some of these include tumor budding. Now, tumor budding is defined as a single cancer cell or small clusters, less than 5 cancer cells in the stroma. Now, this tumor budding corresponds to the non-cohesive pattern of invasion, such as worst pattern of invasion 4 and 5. By definition, tumor budding should not be associated with pattern of invasion 1 to 3. Now, it is a promising prognostic factor, and it is associated with lymph node metastasis and survival. At this point, it is not included in minimal data sets for reporting, but one can always collect this information for future studies. These are examples of tumor budding when we can see the smaller tumor clusters or single cells away from the main tumor in the stroma. Another parameter is tumor stroma ratio, or TSR, which is defined as proportion of tumor tissue relative to the surrounding tumor tissue, and a cutoff of usually 50% is used in majority of the studies. Now, it has been shown that tumors with high proportion of stroma or stroma-rich tumors have been associated with worse disease-specific survival and disease-free survival, and they show higher risk of recurrence. Now, it has potential to be included for routine diagnostic use and clinical decision making in future, although at this point it is not mandatory. And just to show you a few examples, this is on left-hand side. A is a stroma poor or low proportion of stroma in the tumor, and right side it is the tumor showing high proportion of stroma. Now, the last parameter is lymph node ratio, or LNR, which is also known as lymph node burden, defined as the number of positive lymph nodes divided by total number of nodes excised. It is regardless of the extent of neck dissection. Now, what is the cutoff used? Majority of the studies, they have used cutoff as 2, 3, or 4. Now, LNR represents a strong independent prognosticator of oral cancer outcome, and it is associated with worse overall survival, disease-specific, and disease-free survival, as shown by a recent meta-analysis by Sai. Now, it has additional prospective high-quality studies are still required to determine the use of this LNR for routine diagnostics, and the optimal cutoff should be found out. So, to summarize, again, we need to understand what are the essential parameters you expect in a report for risk stratification for the particular patient, and these include tumor site, tumor dimensions, which is largest, histological tumor type, grade, DOI, WPOI, bone invasion, PNI, LVI, margin status, number of lymph nodes involved with ENE present versus absent, and pathological stage of tumor. While there are other parameters, including tumor focality, rest of the dimension, coexistent pathology, and ancillary studies, these are not essential, may be included in the report. There are other promising parameters we just discussed, and they may have some potential to be included. So, take-home message is tumor staging is the keystone for proper management of oral squamous cell carcinoma. HSSC 8th edition have included additional parameters such as DOI and ENE for better risk stratification, and studies have showed that HSSC 8th edition risk stratification is superior to the previous version. There is upstaging of tumor seen in many cases. Now, staging includes various prognostic parameters defining T and N stage, but additional or essential or core prognostic parameters are also required to be documented. And there are certain promising parameters, as we discussed just now, which need to be investigated further. With this, I conclude my talk. Thank you very much, and it's open for questions.
Madam, just for the time, we are just running out of time, I think.
Yeah.
Just I have two questions to you, and maybe Monica Madam also can answer. As a clinician, the most important factor for us is TNM. Other than that, there are some certain factors which we say at other factors like PNI, LV, all this. So my first question is in PNI, what is, means we have definition 30%, or if it is involving one layer of the nerve, it's all take. But which nerves you consider? Means is it the smallest nerve? Means which nerve you consider? So some of the time, so I was just reading that there are certain literature saying the incidence is 9% in oral cancer. Certain literature says it is 70%. So why this difference? If you can just.
So the reason is the definition of PNI has been used differently in different studies. But most common definition that we use, and majority of the studies they have used, is either the tumor should penetrate one of the layers of the nerve, or it should be completely encasing the nerve at least more than 33% of the nerve perimeter. So in that case, we can call it as PNI. And any nerve, let it be intratumoral or extratumoral, let it be small or large, if we see this, we call it as perineural invasion. If it is extratumoral or intratumoral, we specify that. And the largest nerve, whether the size is less than 1 millimeter, above 1 millimeter, that we can specify. Munita, you want to add something?
No, I completely agree with what Dr. Asabri has said. And most of the times what we report is microscopic PNI. These are nerve twigs less than 1 millimeter, and they are many times within the tumor. So, but it's important. And now we have started qualifying it further, whether they are extratumoral as well, because extratumoral PNI is associated with far worse prognosis than intratumoral PNI. Nerves, in the diameter of the nerve which is involved, if it is more than 1 centimeter or any larger trunk is involved, that is also associated with the increased recurrence. And there is also, we can quantify whether it is extensive or it is focal PNI. So extensive PNI meaning we are finding many foci of PNI within a single section is also associated with worse prognosis. Or so we can supplement the current presence or absence of PNI with further qualifying whether it is extratumoral, whether it is involving the larger nerves, or whether it is extensive. So that gives additional information about the biology of the disease. So, but most of the 90% of the times we'll see these are microscopic small nerve twigs, less than 1 millimeters in diameter.
And if we going on discussion on this topic, I think whole night will go. Is the most I think controversial topic. Lot of things. But before I was discussing with Poonam, and she told very clearly, don't discuss in detail because people are postgraduate ready. They will be totally confused. But just to say them that there are lots of factors other than tumor stage, nodal stage, and distant metastasis, which also decide on the prognosis. Last question, madam. There are a lot of time we send a specimen with a two scenario, verrucous hyperplasia, verrucous-like lesion, and you report that there are areas where you find invasion. Now, in this scenario, what should be the tumor stage? What will be the dimension of the tumor we should consider? And in some of the times you write that in the specimen that there is a focus of tumor and that there is surrounding peritumoral inflammation and all. So when you decide, when you report, it is most of the time it is the gross dimension. But how it changes, or whether we should consider these gross dimension only as a tumor dimension, or we should consider actually the microscopic distance.
So, as I said earlier, if there is any change in the microscopic dimension, when we see under microscope, if we think there is a discrimination between what we see grossly and what we see microscopically, then we take this as a microscopic dimension and we specify microscopically tumor measures so and so, and that should be taken as the correct dimension. So, and then any stroma that is not included surrounding the tumor, we don't include the stroma for the measurement. It is only the invasive tumor part that has to be included while measuring the tumor size. Is that, I hope I answered it.
The gross has to always be corroborated with the microscopy. So it cannot be only gross. Microscopy has to confirm it. And ultimately, finally, both are taken together and microscopy has to confirm so inflammation and all is discounted. It is not regarded in the tumor size.
Thank you, Dr. Asavari Patil ma'am, for the wonderful talk on a very important topic. And I also thank our expert panels, Dr. Munita Bal ma'am and Dr. Saurabh Datta sir, for their vital points on this topic. Now moving ahead to the last session of today's conference. The topic is role of radiotherapy in oral cancer. The expert for this topic is Dr. Simon Pavamani. He is Professor, Radiation Oncology, CMC Vellore. The talk is given by Dr. Sarbani Ghosh Lashkar. She is Professor, Radiation Oncology, Tata Memorial Hospital, Mumbai. I request Sarbani ma'am to please share her screen.
Good evening, everybody. And I can see that I'm really keeping you away from your beds on this Saturday evening. And I don't know how many surgeons are really going to be interested in listening to radiation therapy at this time of the day. And thanks, Simon, for sticking around. And I thank the organizers for this invitation. So let's get started. So can you see my slides?
We are able to.
Fine. Good evening, everybody, once again. And I'd just like to start by saying that the choice of treatment in head and neck cancer takes into account the chances of disease control, which are a function of the site, extent, and stage of disease, the anticipated functional and cosmetic outcomes, and of course, importantly, the availability of resources and expertise. Now, when we talk about early cancers of the oral cavity, traditionally we've been taught that it should be either surgery or radiation therapy. However, there is no randomized evidence to support this, and most series are retrospective in nature. What has also emerged from all these years of practice is that surgery remains the mainstay of treatment, essentially because it's a single sitting treatment. And post-surgery, we have the histopathology, which helps us to prognosticate and determine adjuvant therapy. And of course, repeated procedures may be possible in the well-selected patient, and hence it remains the treatment of choice. So if you look at data that is available, this large NCDB analysis, which actually looked at patients between 2004 to 2013, studying early stage oral cavity cancers, what was seen was that of the 20,779 patients studied, only 4.6% of the patients, that's about 956 out of these 20,000 plus patients, underwent primary radiotherapy. And what you will also notice that the patients who were likely to receive radiotherapy were those patients in whom surgery could not be considered. Essentially, they were the elderly, black race, Medicaid or Medicare insurance, or no insurance, oral cavity subsite other than tongue, with a clinical stage 2, low volume treatment facilities, and earlier treatment years. What they also concluded from their analysis was that it was associated with increased mortality, and 5% of patients who receive primary radiotherapy, this percentage was also further reducing. And this was the kind of survival probability after using radiotherapy alone in early stage cancer. However, despite this, then in some cases, radiotherapy is now the treatment of choice, remains the treatment of choice. These are certain sites within the oral cavity, or where candidates are not medically operable, or the patient refuses surgery. So this brings us to the various forms of radiation therapy. This I've said, kept it very simple for the surgical colleagues. We have external beam radiotherapy, or we have brachytherapy, and sometimes we do use a combination of external beam radiotherapy and brachytherapy. Now, what is head and neck brachytherapy? It is the placement of sealed radioactive sources into or immediately adjacent to the target tissue, and this is a form of brachytherapy is necessary because it is the ultimate conformal form of therapy. The rationale to use it is almost practically like surgery. There is rapid fall-off of dose outside the implanted volume, good local controls, comparable functional and oncologic results with acceptable complication rates. Now, what are the various forms of brachytherapy that we can do in the head and neck? We have interstitial brachytherapy, where we put the tubes and the tubes in the tissues, and these are essentially sites like the lip, buccal mucosa, tongue, tonsil, and other oropharyngeal places. Also, we have the neck, sometimes in the PNS. Surface mold, where we have surface lesions over the hard palate, nose, face, pinna, external auditory canal, or it could be endoluminal or endocavitary, like in the nasopharynx. Now, what are those ideal sites within the head and neck, and especially the oral cavity, that are suitable for brachytherapy? Radical brachytherapy is the treatment of choice if radiotherapy has to be done, especially for early lesions of the lip, buccal mucosa, early tonsil, uvula. It can be used as a combination or as a boost after external beam radiotherapy for base of tongue tumors, large tonsillar and soft palate tumors where we need to treat the neck also. Now, how do you select patients? Broadly, they would be T1, T2 tumors, surface tumors, accessible, adequate mouth opening, lesions not very close to the mandible, and they should be node negative or should have a low likelihood of nodal involvement. Now, these are the usual parameters for selecting cases for brachytherapy in the oral cavity. Lip, buccal mucosa, floor of mouth. Again, we've learned from the N0 trial that tumors less than 3 millimeters would have the lowest propensity for lymph node involvement. And because we cannot accurately determine preoperatively what is the likelihood of lymph node involvement for smaller lesions, it would be best to restrict our cases for radical brachytherapy to these kinds of cases. And of course, if you have larger proliferative, largely exophytic tumors, you could have a combination of external beam radiotherapy and brachytherapy. So what kind of cases can be selected? Lip cancers located like this. I know lip cancers today do not form a part of the AJCC staging, but lip cancers and buccal mucosa cancers at the commissure, these are cancers that can be considered for radical brachytherapy after an adequate staging workup has been done. Now, for this case here, I would perhaps choose a combination of external beam radiotherapy and brachytherapy to be able to adequately treat this patient. Now, these are the JEC-ESTRO recommendations of brachytherapy for head and neck squamous carcinoma. And you can see here in this table that the site, the selection of patients, the implant technique. By implant technique, I mean is what we usually do is place stainless steel needles, and these are replaced by nylon catheters. But in some institutes, they do keep stainless steel needles still in situ. We give a margin around the gross tumor, and these are the kind of doses that are needed with outcomes like this. So they are good, comparable outcomes, and of course, in the well-selected cases, you would also get good, hardly any morbidity. Now, the only worry after doing radical brachytherapy is the worry of a late nodal recurrence, and this highlights the issue of choosing patients appropriately. Thinner lesions, superficial lesions, lesions and sites that have a low propensity for lymph node involvement, so that you have less likelihood of lymph nodal recurrence, and this is data from PGI Chandigarh. Now, this is a table again from the same paper which summarizes the local control rates after brachytherapy alone, with excellent local control and 5-year survival, and even with use of brachytherapy as a boost. Now, these are the clinical outcomes again for my surgical colleagues. Excellent local control, cosmetic outcomes following brachytherapy. Again, this is a lesion on the lower lip. Again, excellent controls. You can hardly make out where the lesion was located, and also the deleterious effects of radiotherapy cannot be made out at all. Now, brachytherapy in summary is actually an excellent modality for treatment of select group of patients with good local control rates, good functional outcomes and cosmesis, and minimal late effects. Though surgery is the treatment of choice in early disease, adjuvant radiotherapy may be necessary even after complete surgery. And this is because about 15 to 25% of patients in early stages are aggressive, require adjuvant therapy, and various high-risk features have been identified. So what are these features? Perineural invasion. Again, I will not go into the details of these studies, which I had meant to go in simply because of the paucity of time. This is a study that actually shows that PNI is an independent indicator of adjuvant radiotherapy in the absence of positive lymph nodal disease. This is again data from our institute, which again shows that there is a need for adjuvant radiotherapy, and adjuvant radiotherapy seems to help patients do better than in the absence of adjuvant radiotherapy. But remember, there are an equal number of papers in literature that point towards an equivocal effect of adjuvant radiotherapy in the presence of PNI. But what I'd like to tell the students in the audience that the presence of the PNI portends a higher T stage, also could be a harbinger for regional recurrence, especially in the absence of adequate lymph node dissection. In the absence of other adverse features, what you need to do is qualify your PNI further. We've heard Dr. Asavari speak about this. You need to know the size of the nerve involved, intratumoral, peripheral, or extratumoral PNI, the number of foci, and the density of PNI. Now, this is the NCCN version 1 early in 2022. The NCCN again highlights other risk features, and here they also talk about perhaps intensification of therapy. And one of the trials that is looking into this is the RTOG study, which is using adjuvant setting with adjuvant radiotherapy. Also been proposed. Again, I'm not going into this because we've discussed and heard about this extensively through Dr. Patil's lecture. I will not be going into this, but remember, today we also look at various other features beyond the cut margins and the lymph node status, that is perineural invasion, worse patterns of invasion, lymphocytic infiltrate, and tumor budding. And this is the risk stratification that has been suggested by Brandwin Geinsler based on these parameters. And these actually can be validated into two different groups. And the time to disease progression and all-cause deaths are also related to these groups, risk groups. Now, this is a study from Alman Ghosh, which actually looks at various prognostic indicators in early stage oral pharynx, oral cavity, oral tongue cancers. And what you realize is a depth of more than 4 millimeter, tumor budding, a worse pattern of invasion are significant predictors of disease-specific survival and may actually need treatment intensification. What about advanced stages? Definitely, we know that single modality treatment is ineffective, can reduce local and loco-regional recurrences, and they have been studied. This is a large series from our center, 1,000+ cases studied, and we realized that definitive radiotherapy alone was not sufficient for advanced stage tumor. Surgery with negative margins followed by adjuvant radiotherapy was the way to go. These are various other series available in literature. And one of the first randomized trials in this adjuvant setting for advanced tumors was from India itself. And they had about 58% tumors who received only surgery. And they realized that in these advanced tumors, surgery alone was not enough. You needed adjuvant radiotherapy to improve the disease-free survival. Now, we shall look into these various other parameters about adjuvant radiotherapy. So there are various risk groups that have been found. And based on the primary and nodal features, Dr. Asavari has again gone into details about this in her lecture. So I will not go into these again for want of time. This is again another important study by Langendig's group, which has divided patients into 3 RPA classes, again based on surgical margins, extranodal extension, T size, and the number of lymph node metastasis. And again, if you look at these 3 classes actually have outcomes that are very different, all in terms of loco-regional control, distant metastasis-free survival, disease-free survival, disease-specific survival, and overall survival. And this can be seen very clearly in this graph. Radiotherapy, you need to give doses above 60 to 65 gray, and I shall be coming to some randomized studies about this. What about the timing of radiotherapy? It should be given as soon as the wound heals, but no later than 6 to 8 weeks after surgery. What about the overall treatment time, or rather the package time, usually not to exceed more than 100 days. And again, I'll be coming to a study to show all these parameters. So this is again a seminal trial which was done at the MD Anderson with Kian Ang as the late Kian Ang as the PI. This was a study that was designed to actually study the validity of using pathologic risk features, as well as the dose of post-operative radiotherapy, the impact of accelerating radiotherapy using a concomitant boost schedule, and the importance of overall treatment time. So if you look at this, there was a definite difference in outcomes between these three risk groups, 288 patients. And also in patients where there was a delay in starting radiotherapy, and if you delivered the radiotherapy quickly, you could achieve better outcomes despite the delay. Also, if you look between the locoregional control, there seems to be a definite advantage in the group that finished radiotherapy earlier. And the effect of the overall treatment time is also very obvious, that patients who had more than 13 weeks from surgery to completion of therapy did much worse than those who finished treatment within 11 weeks. But what you have to remember, and what is very essential, that with combined modality management, the chances of acute and late toxicities also go up. Now, is there an advantage of escalating the dose? Again, this is the same study by Lester Peters. And what we realize here is that there is no advantage between the 63 gray group, which is the highest dose, in even the highest risk patients. And this is true even for patients who have very high risk features like positive surgical margins or extranodal extension. These are the graphs for all these various groups. Now, about radiotherapy in particular, we've now moved from a very wide field radiotherapy to more conformal radiotherapy in an attempt to try and reduce reactions as well as sequelae of treatment. There are various consensus available about what kind of volume should be included. We have moved away from these rectangular fields to more conformal fields so that we can protect the adjacent structures better. Now, despite using adjuvant radiotherapy, we do see cases that fail locally or locoregionally, and these are essentially seen in patients who have multiple lymph nodes, extranodal extension, and positive margins of resection, which tells us, or rather indicates to us, that we need to intensify treatment. So what are the ways we can do it? We can do adjacent concurrent chemoradiotherapy, altered fractionation radiotherapy, or concurrent radiotherapy with targeted therapies. So all of you should be aware of these two pivotal trials, the URTC 22931 and the RTOG 9501, which randomized patients with so-called high-risk features into two arms, that was adjuvant radiotherapy alone versus adjuvant CTRT. The URTC had several other parameters, while the RTOG essentially had only three adverse features. And this is a meta-analysis, included both these trials as well as certain other smaller trials. It just simply revealed to us that there was an absolute improvement in overall survival of about 12.5% after the use of adjuvant chemoradiotherapy in high-risk patients, though there was an increase in the morbidity associated with treatment also. And the maximum benefit was in those patients who had extranodal extension and positive cut margins, with poorer benefit in patients who were more than 70 years of age, and there was a need for intense supportive care. The long-term results of this trial also confirm the same. Now, we've said all this, but we still realize that not all patients with advanced stage disease can receive surgery or can receive surgery followed by adjuvant radiotherapy or adjuvant chemoradiotherapy. Then is there a room for definitive chemoradiotherapy in these patients? Again, as in the early stage, we do know that whenever possible, surgery followed by adjuvant therapy should be the treatment of choice, and this is quite apparent from the sensitivity data analysis. However, what we also need to understand, again, this is another large NCDB analysis proving the same thing, but what we need to understand is that there are still a group of patients who would receive concurrent CTRT with advanced stage disease, and they do have some amount of survival, which is reasonable considering that they are usually the poor prognostic group. Typically, the patients who receive non-surgical treatments are those who are more elderly, non-white race with significant comorbidity, advanced stage disease which is inoperable, or no objective criteria for selection of criteria, or maybe in a non-academic setting. And of course, we have no reports on quality of life. But non-surgical treatment is still a viable option when surgery is contraindicated for medical reasons or patient preference. And these are some series that show you what are the outcomes when we consider radiotherapy or radiotherapy with concurrent chemotherapy in these patients with advanced stage disease. This is from Ezra Cohen, and you can see that the 5-year overall survival, progression-free survival, and local control rates are not bad, considering that these are the worst of the lot. This is again another later series from 2000, which from the Princess Margaret Hospital. Again, you can see why surgery was not done in these patients. Most of them were medically inoperable. And again, these are the various dose regimes, the various volumes that were treated, and they were treated with IMRT. And this is the kind of outcome. What you do realize is the adverse feature, of course, is the nodal stage. And median follow-up of 52 months, the outcomes were still acceptable, especially since these patients could not have otherwise undergone any kind of curative treatment. But you have to keep in mind that there may be a high chance that a good proportion of patients may have severe sequelae of treatment, but it still remains meaningful in patients who can otherwise not be considered as candidates for radical surgery. These are several other series which have evaluated concurrent CTRT or RT alone. And I would request you all to also have a look at this and not write off patients, especially if patients are in reasonable performance status, have a chance at some form of prolonged palliation. Now, of course, during the COVID times when surgery was being done less and less in patients, this particular rapid review and meta-analysis did show that there was no increase in hazard of death with definitive CCRT. Now, we have to understand toxicity when we use multimodality therapy or when we use radical radiotherapy or radical chemoradiotherapy. But of course, this data in Michelle Macthay's series is from the pre-IMRT era, but we still need to keep this in mind and understand this very well. There is another very important role played by radiation therapy in oral cavity cancers, and that is for palliation. This is essentially, it can be offered for patients who are in poor performance status with comorbidities, and they are effective in patients with fungating nodal masses, bleeding occasionally, pain, metastatic disease, and usually the treatment regime used is a hypofractionated. That is, we try and finish the radiotherapy as soon as possible. So in conclusion, radiotherapy can be used in the radical setting in early stage for highly selected group of patients. Preferably, this should be brachytherapy alone. In advanced stage disease as adjuvant radiotherapy or adjuvant concurrent chemoradiotherapy. For those patients who cannot undergo surgery, it should be a combination of RT or CTRT. And in advanced stage disease, it can be used for good palliation. The relative contraindications for the use of radiotherapy, of course, include orocutaneous fistula and cross-mandibular erosion. I'd like to conclude with these tables because they give you an idea of how radiotherapy can be used in the primary setting, in the adjuvant setting, and of course in the salvage setting. Thank you very much, and sorry for keeping you up so late on a Saturday evening, that too with academics. Thank you very much. I'll be happy to take any questions, or Simon, if you've got anything else to add.
So I think Dr. Sarbani, you covered everything and in a short time. So I think I'm not sure if there are any questions in the chat box. So I think I'm being a program aimed at surgical trainees, I think we have covered.
Why to avoid RT in gross mandible invasion? Can I answer that question, Simon?
Yeah. Sure.
So, Rajal, I am not saying that you avoid adjuvant radiotherapy. I'm talking about definitive radiotherapy. When you have gross mandibular invasion on your histopathology after a surgical excision, yes, please do use adjuvant radiotherapy. You have to. but not when you've got it as gross involvement in the definitive or when you're not operating upon the patient. That's what I meant by saying that that was a relative contraindication to radiotherapy. In the adjuvant setting, definitely. What is the role of neoadjuvant chemotherapy in head and neck cancers? Should I answer that question? I think we did talk about this, so you would have to divide it into oral cavity and non-oral cavity and or perhaps nasopharynx. In nasopharynx, there is a definite role. In oral cavity cancers, for resectable oral cavity cancers, it should still be surgery followed by adjuvant RT, CTRT. Maybe in the borderline resectable or the unresectable cases, you can use neoadjuvant chemotherapy. In larynx and hypopharynx, again, you have evidence for the use of neoadjuvant chemotherapy, especially for advanced hypopharyngeal tumors. And of course, if you look at the meta-analysis, you will realize that there seems to be an advantage for using the triple drug versus the two drug regimes. So it will depend upon the site. Oh, somebody is asking me about re-radiotherapy. Oh, it's nice to see people are still awake and involved. Okay, Anshu, the thing is that the factors we consider before giving adjuvant re-radiotherapy are usually the same parameters that we consider while giving adjuvant therapy in the per primum setting. I would refer you to the GETEC trial, that is Janot's trial, which is the only randomized trial, though the aim of that trial was different. But the indications, or rather it helps us identify those high-risk patients, but the indications are more or less the same as what you would do when you were going to give radiotherapy, adjuvant radiotherapy in the per primum setting. But then it will be determined by various other factors like sequelae of prior therapy, interval between the first disease and the second setting of radiotherapy, and parameters like that. Patient develops orocutaneous fistula mid-treatment, how to proceed. So what we typically do is that when a patient develops either a wound dehiscence, a breakdown, or a gape during radiotherapy, we usually look at a few things. How far along in radiotherapy is he or she in? What are the parameters, or rather the factors for which you are going to be are giving adjuvant radiotherapy? And where is the location of this fistula? You know, sometimes if it's lying at the corner of the tri-pointer and it's bang on the carotid, you would be a little wary of continuing with your radiotherapy. But supposing if it's in the submental area, it is small, you're well along into your radiotherapy, almost 4 weeks or more, you may continue it together with your surgeon supervising this patient. But yes, if it's a big gape, the bone is exposed, I may stop radiotherapy. So it has to be individualized, very difficult to generalize this situation.
Yeah, so I'd just like to add that whenever we have patient who's post-operative and has risk features which are not the standard indications, like PNI, and you have a DOI, where we think or it's a tongue cancer, we would sort of have a discussion with the patient and have an informed discussion and then offer radiation, because we don't have clear-cut evidence, but we can use the retrospective evidence and the small data to advocate or push for post-op radiation.
That's how we do it also. Luckily for us, for some of these patients who are really borderline, we have the ARREST trial that is going on in our institute. So we do encourage them to participate in the trial. But otherwise, we again tend to distinguish between buccal mucosa and tongue floor of mouth. And of course, the patient is made to understand the pros and cons of offering adjuvant therapy. Hanish George is asking, any role of pentoclo protocol in ORN? Yes. That is one of the protocols that we do follow in ORN today. And we do use it for a prolonged period depending on how this patient is responding to it. And this is especially important for those patients who have an obvious discharge from the site, where we're not going to be considering surgery just now. We do put patients on the pentoclo protocol actually. Patient with buccal mucosa T2, N0, M0 treated with adjuvant RT alone 3 years now with the recurrence of the infrared dose needed, madam. Dose needed, madam, but I don't know what kind of a recurrence this patient has, Vidya. That would be important to understand. What kind of a recurrence he or she has, the volume of the recurrence, is it amenable to surgery? If it is not amenable to surgery and the patient is in good performance status, I may still consider, since that patient has a DFI of 3 years, I may want to consider giving some form of systemic therapy or systemic therapy with concurrent radiotherapy, depending on whether I can give a sizable dose, which would be about 66 gray. And this would also be determined by the dose that this patient has received in the past. So, Simon, would you agree with me?
Yeah, so we would actually try and see where if we have the details of the radiation, we would see how much radiation has already gone, and we will sort of calculate the risk and see how much we can safely deliver. Definitely would like to give radical doses. Explaining to the patient the side effects will be much more. And for all recurrences, we do a 4-vessel Doppler of the carotids to ensure that we are not compromising any of the carotids. Of course, a good dental evaluation to make sure we understand the risks of radionecrosis, osteoradionecrosis.
Till how many days can RT be delayed if surgical defect is not healed? Sorry, Rajal, this is something that I always discuss with my surgical colleagues. And that is, whatever this flap they choose and whatever kind of reconstruction they choose, it should be such that they do not forget the oncological outcome. Very many times with the free flap, you get carried away with just trying to restore cosmesis form, and then the wound keeps breaking down again and again, and then you delay radiotherapy. And this is especially important in those patients who've got very high risk features. So, as I said, the overall treatment time should not preferably exceed 100 days. The time interval between surgery and radiotherapy should be such that as soon as the wound heals and the sutures are out, you can start radiotherapy. But we try not to exceed anywhere between 6 to 8 weeks, preferably 6 weeks and not 8 weeks. So this is what you have to look at. So I urge all the surgeons and the students in the audience to actually look at this and pay attention to this when you're considering surgery, and especially when you do primary reconstructions, please see to it that there is no tension along your suture lines, because invariably the suture line breaks down, or if you have a tri-pointer that is very tight, you break down at the intersection of the three scars, or especially in the area of the malar prominence, there are wound breakdowns that are seen very commonly. And that is another thing that we're very scared of. And especially sometimes when we use the split skin grafts, that's again another thing that breaks down very commonly. So please keep this in mind, because adjuvant therapy should not be forgotten. And beyond a particular time interval, it's practically of no use. Then you give it or don't give it, you may cause morbidity and actually not gain anything.
The other thing I'd like to say is, if patients have high-risk features like positive margins or extranodal extension, sometimes when the delay is more, we have actually seen recurrences while we are still waiting to start radiotherapy. So then we are actually lost the battle.
And if you remember what I showed you from Kianang's paper, perhaps if you exceed that time of 6 weeks or so, it may be an indication if the wound has healed well, provided it has healed well, that you can accelerate therapy so that you still finish your entire treatment within the 100 days possible. But it's very important to keep in mind all these parameters when you're reconstructing.
So, ma'am, thank you. With this, we conclude today's session. I would like to express my thanks to Dr. Sarvani Ghosh Lashkar, madam, for such a informative lecture, and Dr. Simon Pavamani, sir, who spared his time so late in the evening and gave us valuable inputs. I would like to thank all the esteemed expert panelists and our very enthusiastic delegates who made it a very useful and entertaining session for all of us. So I would be meeting you tomorrow at 9:30 a.m. sharp for the second day of our this program, which will be mainly for the thyroid, larynx, and parotid. So with this, we conclude today's session. Thank you very much, and good night to all.
Good night.
Good night.
Good night, sir.
Recording stopped.
Can we close? Hello, ma'am. Hello,
Can
ma'am.
we close? Yeah, please close the session. Thank you so much.
Please save the chats also.